Hi guys, a very good evening to all of you. So, a very good evening once again, and just give me a quick input with respect to the audio and the visual part, and then we can get started for today. So, it's that time of the year when the pressure tends to build up, and when we tend to forget a lot of things, and we think that we have not studied anything. Though I've tried to cater to the same thing also. Yesterday, I put up a video in which I mentioned regarding very common things that we tend to experience as the date for the exam comes closer, and it's based on what I have gone through when I was a student at your time. So I mean, everything that I've said is very practical, and I've tried to I would say practice it on myself before telling it to you guys. So it's not simple preaching. It is that whatever hacks or whatever solutions that I have tried to say in my yesterday's filter the unfiltered video, I have tested them on myself before actually sharing with you. So great guys, thanks for the inputs with respect to the audio and the visual part. Dr. Ayushi, Dr. Anand, Dr. Shubham, Pranchu, Dr. Anand Mani, Dr. Dipesh, Yogesh, Sive, Ibiza, yep. And yeah, doc, somebody mentioned for FMGs also, so we'll be doing more sessions definitely. And Aparna, yes, you'll do great. Hi Harsh, Lakshmi, Manisha, Krish, Paul, Sujit, Nihar, Navjeet. So thanks guys, and I think we can get started. At this moment, my first message is, I mean, one of the main objectives of today's video is keep the focus so that you don't accelerate too hard. You know what lot of guys are doing today is, and now doing nowadays is that they're pushing themselves too hard, and when you rev on the accelerator too hard, and when you generate more torque, and when you generate more horsepower, your car can go off the track also. So you will come back. You can see this guy, he is gonna come back on the track definitely, but then you see it is consistency that matters. So on a daily basis, keep on doing questions and try to ensure that whatever you done yesterday, exceed that for today. Yeah, Shubham, some of the questions are very simple and straightforward, so I think that it should be useful for you. Yes, Sajid, hi, then Dr. Shweta Kumari, Rajni, Shubham. Let's get started. The first question for today. Let me have inputs from you guys with respect to the first one. The question talks about Monday's disease, and I thought that in the opening session, let's keep some straightforward ones, and then we can get the rhythm going, and we can keep on pushing ourselves to more, difficult ones. So I'm still waiting for your answers. Pretty straightforward ones. Monday disease. So we read about Monday chest tightness with respect to bisonosis, but with respect to this, I think everybody is very clear, very straightforward answer. This guy is an industrial worker, and this guy would be having tolerance to nitrates. Like you very well know that we don't use nitrates on a regular basis for angina. I have explained that we tend to stagger the dose of nitrates per se. So whenever we are giving nitrates to an individual, we have to ensure that he does not end up with development of tolerance. No guys, for people who are saying B, all I can say is silly mistakes are to be avoided. The answer to this particular question is not definitely option number B. We're not talking about Monday chest tightness. We are rather talking about Monday disease. So I'm still getting B in the feed. I repeat once again, guys, do not make silly mistakes. Lot of questions in the exam are going to be very simple and straightforward, piece of cake for you. So just for the record's sake, though, I think this was one of the easiest ones that I'll discuss with you. When we talk about bisonosis, we talk about Monday chest tightness, but I am talking about today not Monday chest tightness. I'm talking about an industrial worker who's having exposure to nitrates. And what are gonna be the symptom on this guy? Most of the time, there's gonna be dizziness because there's gonna be hypotension. There is gonna be a compensatory increase in the heart rate, so there's gonna be a tachycardia. And because of dilatation of the brain blood vessels, there can also be development of stretching of the dura mater. That stretching of dura mater will cause severe headache. All these symptoms will be present mainly on Monday. By Tuesday, Wednesday, Thursday, there's gonna be a development of tolerance, but then Saturday, Sunday maybe is gonna be a holiday. At least Sunday is gonna be a holiday. So once he is gonna be going on the weekend, then the exposure will not be there and the tolerance will go away. And once the tolerance goes away, when he comes back to work on Monday, he again starts having manifestations. So the answer in this particular case is option number A, and it is nitrates exposure, which will definitely cause a problem. And too much of this can contribute to development of methemoglobinemia in these patients as well. That methemoglobinemia component I've written on the left hand side just to say that that would be toxicity. And yes, happiness zone, you perfectly right. Monday disease versus Monday chest tightness are two separate aspects. So pretty straightforward. Answer to this question is A. And I just wanted to highlight that you should be avoiding silly mistakes. So let's take up the hardcore aspects now. We are talking about a patient who's having pulmonary artery hypertension. And in this chap, the pressure is definitely going to be elevated. I mean, you very well know the average values of doctor, it is not Monday fever, it's Monday chest tightness. So please be clear about it. The normal pulmonary artery pressure, you very well know the mean values are something in the range of about 15 millimeters. And if it goes beyond 25 to 30, in fact, in some books, he will talk about even values of about 20 to 25. So I can say anything value more than 20 is definitely to be considered as pulmonary artery hypertension. And the question says which of the following is gonna be a feature which is present in these patients. Let's see what guys are saying. I'm getting you have to comment as 1 2 3 4 and not as A B C D because the options will vary. Okay, fine. I'm still getting A, B, C, D as a feed, so please understand you have to answer as 1, 2, 3, 4. Maybe if the screen is a little bigger on the bigger side, we can narrow it down here also. So first of all, first and foremost, what I want you to understand is that in any chap in pulmonary artery hypertension, what will happen is that the pressure in the pulmonary artery will cause increase in right ventricular and diastolic pressure because the ventricles will anyway have to work against a resistance. When the right ventricular and diastolic pressure will increase, the pressure in the right atria will also increase. And when the pressure of the right atria will increase, yes Avinash, you have been spot on in your answer. When the pressure right atria में बढ़ जाएगा तो होगा क्या कि all the venous, I would say the epicardial venous flow, the inflow of the epicardial veins will become relatively lesser, and if there is a lesser epicardial venous flow, that will explain the pericardial effusion in the patient. In fact, because the pressure in the right atria will be more, it will also cause a decrease in the lymphatic flow towards the heart. So there are two things which are happening in the patient. पहला क्या हो रहा है कि जो एपिकार्डियल वेनस फ्लो है, जो हार्ट के खुद का जो वेनस फ्लो है वही हैम्पर हो गया, सेकेंड लिम्फेटिक फ्लो भी हैम्पर हो गया. सो बोथ ऑफ दीज विल एक्सप्लेन व्हाई इज गोना बी देयर अ डेवलपमेंट ऑफ पेरिकार्डियल एफ्यूजन. तो आंसर आई मीन बिफोर आई कमेंट ऑन द आंसर मैंने लॉजिक बोला दैट पेरिकार्डियल एफ्यूजन इज अ फीचर ऑफ पल्मोनरी आर्टरी हाइपरटेंशन. क्यों होता है उसका लॉजिक मैंने यहाँ पे बोला कि इट इज एलिवेटेड प्रेशर इन द कार्डियक चैम्बर्स. वो एलिवेटेड प्रेशर इन द कार्डियक चैम्बर्स की वजह से हार्ट का जो खुद का वेनस रिटर्न है, जो लिम्फेटिक फ्लो है, जो राइट एट्रियम में एंटर करता है वो कर नहीं पाएगा, जिससे पेरिकार्डियल एफ्यूजन डेवलप हो जाती है. ऑप्शन नंबर बी में लिखा नैरो स्प्लिट सेकंड हार्ट साउंड. तो प्रेशर इन पल्मोनरी आर्टरी इज मोर, सो इट विल पुश द पल्मोनिक वाल्व. आई हैव एक्सप्लेन्ड दिस कि A2 होता है, P2 होता है, तो A2 में तो कोई दिक्कत नहीं है, पर व्हेन इट कम्स टू द P2 ऑफ द पेशेंट तो होगा क्या कि द प्रेशर विल पुश, पीछे से धक्का मारेगा तो P2 विल कम क्लोजर, एंड व्हेन द P2 विल कम क्लोजर तो गैप लेस हो जाता है, तो नैरो स्प्लिट सेकंड हार्ट साउंड भी हो जाएगा. पल्मोनरी आर्टरी हाइपरटेंशन के पेशेंट में रिकरेंट सिंकोप का लॉजिक यही है कि ब्लड विल नॉट बी एबल टू गो इन द पल्मोनरी आर्टरी. इफ देयर इज लेस गोइंग टू लंग्स, लेस विल कम टू लेफ्ट साइड, सो इनपुट इज लेस, आउटपुट विल आल्सो बी लेस. तो ABC इसका सही बनता है. अब आप देखो वेजो रिएक्टिविटी टेस्टिंग. तो वेजो रिएक्टिविटी टेस्टिंग तो खुद में ही क्वेश्चन है. Vasoreactivity testing is gonna be done with help of inhaled nitric oxide, and when you give inhaled nitric oxide, it will cause dilatation of the pulmonary artery. When you say positive vasoreactivity testing, then positive vasoreactive testing means that there is gonna be good response to calcium channel blocker. In option number D, it is written wrongly. It is epoprostenol. Yes, we use epoprostenol infusion for these patients. Yes, Dr. Sandhya, I will be using English here mainly. Inhaled nitric oxide, positive response means that there's going to be good response to calcium channel blocker. So the problem with option number D is epoprostenol infusion. This is the wrong thing at this particular point of time. What you would be using in these patients is going to be like amlodipine 10 milligram twice a day. So it has long-acting calcium channel blockers which should be used if there is a positive response. On the contralateral side, yes, Dr. Muhammad, I'll be using English primarily. On the contralateral side, if a chap is going to be having a negative response to vasoreactivity testing in pulmonary artery hypertension, then we are going to use prostaglandins for management of these patients. So I think most guys were spot on. The correct answer for this question is option number A. I'm still got B as an answer, so I'll just clarify why D is not a correct statement. I mean that option number D has to be ruled out straight away. In fact, I've covered two MCQs in a single MCQ here. One they have asked in the previous exams, in which condition do you use inhaled nitric oxide? We use inhaled nitric oxide for diagnostic purposes, not for therapeutic purposes initially. We use inhaled nitric oxide for diagnostic purposes in patients who are suffering from pulmonary artery hypertension. What we are trying to see is, will the pulmonary bed respond to CCPs or not? When you say positive response, that means there is going to be response to CCPs. If not, you straight away can go on to usage of specifically prostaglandins for management of these patients. And the prostaglandin that we use here is not alprostadil, right? The one that we use in pediatrics for ductal patency. What we are going to use in this particular case is epoprostenol. So the correct answer for this particular question was mainly based on the fact that option number D had to be ruled out, and then you would be on your way to solve this question. So good job. I think most guys have done a great job with the correct answer to this question, though I did have a variable response, so I think your accuracy will pick up. But the first one was a sitter, the second one is based on I would say the previous data. And the PDF for this I'll be posting in the top educator group. That's our per se the Telegram group. So if you can just search for that, or if you're already a member, the PDF for this would be posted there. So we are sorted with the second question for today. I'm really happy. Good job, most of the chaps. And pulmonary artery hypertension happens to be something that is nowadays being asked. So it's always a good idea to study about it. And I've also talked about, yes, Avinash, you're right. We are having epoprostenol and treprostinil for management of these patients as well. So I think you guys are doing a great job, and just keep the focus on, because what usually happens is when we get few questions correct, we say, okay, fine, aaj to, today is a good day. But the day when you get less marks in a mock test, you tend to feel depressed, especially people who would be getting like 50% wrong in a mock. Out of 200, 100 are going wrong. Out of 300, 150 are going wrong. That day the depression comes. So that is the day which is gonna be tough days for you, but tough days are always followed by good days. So keep the focus on, that is what I said. I mean, try to work on the negatives, whatever that went wrong, have a look at it, why it went wrong. And it is not lack of knowledge. None of you have lack of knowledge, it is lack of application. So all of you are brilliant chaps, all of you will do great in your careers. You need to be all pumped up. Yes, man, I'm gonna do it. And with this, let's move on to the next question. The question says, we should not be using ringer lactate in a patient of. Well, as far as ringer lactate is concerned, there are a lot of things which are to be remembered. In fact, in this particular slide, everything that's mentioned for ringer lactate, what is the pH of ringer lactate, what is the approximate osmolarity, how much is the sodium, potassium, chloride, lactate, every of these values should be, when it comes to fluids, all those aspects with respect to the fluids should very well be in your mind. Now I'm having okay, let's look at I'm getting a 1, and then I'm getting a 2, and then I'm getting a 3 in this particular case. So let's just work it out. Fulminant hepatic failure, you very well know that ringer lactate will be going to the liver, and there the lactate will be converted. The lactate is the one which is going to be utilized for synthesis of bicarbonate. So if a chap is going to be having fulminant hepatic failure, this conversion will not occur. So fulminant hepatic failure is definitely a situation where I would not like to use ringer lactate in the patient. In congestive heart failure, already there is volume overloading. If a chap is having congestive heart failure, he will be having pulmonary edema, he will be having pedal edema. So in a situation of volume overloading, I am definitely not gonna use ringer lactate in the patient. Option number C says hyperchloremic non-anion gap metabolic acidosis. Well, first of all, I want to say the fact that chloride values are elevated and it's a non-anion gap. We usually use it in scenarios where there is going to be hagma, that is a high anion gap metabolic acidosis. And more of all, I would like to say that this is actually a side effect of normal saline. No? When you give too much of normal saline, it will cause excess of chloride in the body. If negative charges will increase, then bicarbonate will increase in the body. I mean, in negative charges, chloride is increasing, the bicarbonate, rather bicarbonate will be lost. I'll repeat my fact once again. When you give too much of normal saline, what happens is that you are giving too much of chloride. When negative charges will increase, the kidney is like a good protective mother. When negative charges will increase, the kidney will try to lose negative charge, what is bicarbonate, and when you lose bicarbonate from the body, then there will be a development of acidosis. So I have tried to explain that in a chap who's given excess of normal saline, you would be having metabolic acidosis developing. That's one of the side effects, and most of the time ringer lactate would be useful for scenarios where a chap would be having a high in Angia metabolic acidosis. Now if you look at D, that is going to be CHPS, congenital hypertrophic pyloric stenosis. The message is that CHPS is associated with, in fact I'll use a different color to highlight it, congenital hypertrophic pyloric stenosis is going to contribute to okay, Dr. Diksha, at the end of it I'll post the link for that also. Otherwise, you can mail me at marwahmedicine@gmail and I'll send you the PDF. Now, coming to the concept, guys, the basic point is that when it comes to CHPS, it's going to contribute to dehydration. When you're going to be having dehydration, RAS system goes up, so there's going to be excess of aldosterone. Excess of aldosterone will cause metabolic alkalosis. Now, you very well know that ringer lactate will also generate bicarbonate. If a chap is already suffering from metabolic alkalosis in his body, bicarbonate values are already more, and if we will give ringer lactate to a chap with metabolic alkalosis, it will worsen the alkalosis component. The logic is, if you are gonna give bicarbonate to a chap who is already having excess of bicarbonate, so on those particular scenarios, you would be causing worsening of the patient. So we don't use ringer lactate in metabolic alkalosis, we anyway use ringer lactate for metabolic acidosis. So for management of these patients, yes, Avinash, you're right, we will be having metabolic alkalosis with a paradoxical aciduria. But the point is, I don't want to worsen the alkalosis component of the patient. So there are three situations definitely where A, B and D are correct. So the correct answer for this particular question would be option number 2, that is fulminant hepatic failure, congestive heart failure, and then is gonna be congenital hypertrophic pyloric stenosis. I'll give a shortcut to this once again. Option A, why is it a correct statement, is because ultimately metabolism of ringer lactate will occur in the liver of the patient. So if liver itself is busted, if the liver itself is destroyed, I'm not gonna give ringer lactate. Option number B was one of the easiest one to pick up in this question. In fact, all the options were having B present. So absolutely not a problem. I would have used anyway, I mean volume overloading concept. And when it comes to option number D, the point is the chap is having metabolic alkalosis, and I'm not going to cause a worsening of metabolic alkalosis in the chap. So the answer to this question is not the first one, guys. It's option number 2, which is to be remembered. And option number C is in fact a side effect of excessive administration of normal saline. Logic is more negative charges. The kidney will try to maintain electroneutrality. Kidney is always neutral. So kidney क्या करता है? If there's going to be more negative charges in the body, it says, okay, I'm going to kick out some negative charges. And when you kick out those negative charges, that is why bicarbonate becomes lesser, and that is why you get metabolic acidosis. And apart from this, I think most guys have been able to narrow down to this particular option. That is option number 2 for this question. If you got it correct, great. No, if not, then just practice a bit and you'll be perfectly fine. And ringer lactate indications are very simple and straightforward. So what I did was I tweaked the question and I moved it to rather contraindications for ringer lactate. Okay. Moving to the fourth one for today. This one talks about this patient who is 60-year-old chap, severe COVID-19, admitted to high dependency unit. So you very well know that in the current protocol for COVID, earlier we were having dedicated COVID health center and dedicated COVID hospital. Now it's not like that. We are not having any dedicated COVID hospital or dedicated COVID health center. I mean, we are just creating separate wards for them. So when it comes to a patient with severe COVID, where will you admit him? You will admit a severe COVID patient in a high dependency unit or in an intensive care unit setting. Whereas when it comes to moderate COVID, then on those circumstances the patient will be admitted in the routine ward per se. So one change you very well will see will be that now we are not using these words DCHC and DCH primarily. So Ayush, you can join the discussion and see whether it's going to be useful for FMG exam or not, because doctorate medical science will not change. No? Disease will still be the same. So some of the questions are very simple and straightforward, especially the one that we're discussing at this particular point of time. So message number one is we are not gonna use DCHC and DCH terms now. It's gonna be either a HDU or an intensive care unit. Okay. Okay, so I'm getting various situations. The question is saying which is not correct. So for people who are mentioning option number B, I think you are missing the bus in a sense that you are missing the wrong statement, because any patient who is having any of the two things, either is having fast breathing. Now suppose somebody is not having a pulse oximeter in the house, but is fast breathing, like suppose ASHA worker. Let's take a very simple situation. ASHA worker who has been trained by the government has reported a person is having fast breathing and is complaining of shortness of breath. Simple, this much information came to you telephonically. A 60-year-old man is having breathlessness. You said, okay man, not a problem, count the respiratory rate. She gave you a routine value, 30, 35, something like that. And there is no pulse oximeter, right? So you're not going to say, bhai, pehle pulse oximeter, get a pulse oximeter, chai value, only then we will admit. So any of the two criteria is more than sufficient for admitting this patient. I mean, for severe criteria, I've always said 30-90, any one of the two. So one, do remember the fact for diagnosis of COVID for severity, you don't need to be rigid in saying that both things should be present. The current guidelines are any one should be present, in a sense that even if you don't have pulse oximeter, no problem. Then is IV fluids to maintain euvolemia. I mean, understandable. You see, this chap for severe COVID-19 will develop ARDS. In ARDS, there is going to be presence of pulmonary edema, and in pulmonary edema, if I will give too much of IV fluids to the patient, it will contribute to worsening of the patient. If I give less fluids, it will cause multi-organ failure, it will cause kidney failure. So I need to achieve euvolemia. For people saying C, please understand, if your patient is sick, what will you recommend? Will you recommend overhydration or underhydration? None of those. I will not recommend overhydration. Why? Because if I give too much of IV fluids to cause a volume overloading, the pulmonary edema component will worsen. On the other hand, if I give too less fluids, it will, I mean, in my hospital, he's breathing, मुंह खोल के सांस ले रहा है यार, the guy is breathing hard, he's having increased insensible losses. In a chap who is losing water in the form of water vapor in a hot Indian summer, we are not going to have air conditioned wards. So B and C are correct. I'm still getting B and C in the feed. Now the feed is between A versus D. Blood sugar to be checked every 48 hours. Why? Because we are anyway gonna be, checking and be worried about the fact that steroids are given in severe COVID. They will worsen the blood sugar values. Sir, complete blood count. Which test is done daily in COVID? Then 3 tests are done daily. What investigation should be done every 24 hours? Then the investigation that should be done every 24 hours is complete blood count, LFT and RFT, because with complete blood count you will be able to determine what is called as neutrophil lymphocyte ratio, NLR. When neutrophil lymphocyte ratio will increase, if NLR ratio is more than 3.5, it means deterioration. Liver enzymes are also deranged, and RFT can be deranged due to dehydration, which will occur due to insensible losses. I don't want a multi-organ failure, so we'll be checking out the blood CBC, LFT, RFT every 24 hours. When it comes to blood sugar and CRP, when it comes to CRP in a patient, when it comes to blood sugar in a patient, the testing would be done approximately every 48 to 72 hours. There is no need for daily sugar monitoring, and this chap is anyway not gonna be a chap in whom he's not a diabetic. And the question never said diabetic. If you look at A, it says non-invasive breathing with a face mask if the work of breathing is too high. Just read this statement. If the work of breathing is too high, can you put a non-invasive ventilation? Absolutely not. For any chap of COVID-19, if the work of breathing is too high, you need to put in an endotracheal tube in the patient, and you need to go in for a tracheostomy. You will go in for mechanical ventilation in this patient. The basic concept is that in any chap with COVID, because you will be requiring admission, what is the diagnostic criteria for admission? The diagnostic criteria for admission would be respiratory rate more than 30 or SpO2 less than 90, any one of the two. Maintain euvolemia in the patient. Blood sugar कब टेस्ट करनी है? तो every 48 से 72 आवर्स पे चेक करनी होती है. But work of breathing being too high, तो वहाँ पे हमें ऐसा नहीं करना है. What I'm sharing before you is the latest guidelines for COVID management, which have been put up on the Ministry of Health and Family Welfare website. You can see this PDF on mohw.gov.in, and when it comes to the update, it is like this, that in any patient, update in a sense that they have just come up the question on logical sense. The basic point is, if you are admitting a guy who's a moderate case, in a moderate case, what will be the first way or what will be the first method of administration of oxygen to a patient? Then your answer will be non-rebreather face mask. It is NRBM which will be recommended for this patient with awake proning. So the message is, how do you give oxygen to a COVID patient who's moderate? NRBM and awake proning is what is recommended with usage of steroids. No worries, Ashwin. I mean, there have to be some questions which I have to introduce as conceptual ones, some have to be simpler ones. So if you look at the first three questions, they were very simple and straightforward, whereas this one is to be remembered. There's a video on my YouTube channel. You can go to Dr. Marwah Live, and there I've talked about oxygen therapy and the various modes of ventilation. Otherwise, you can go to emergency medicine section in the app, and there also I've talked about the various modes of ventilation. In fact, in FMG exam, they have asked regarding the ventilation strategy to be followed in COVID-19 patients. So if you go through the previous year questions, you would be definitely much more comfortable. And on the right hand side, guys, I'll just zoom it in. What you need to understand is, if non-invasive ventilation kab use karna hai with a helmet, face mask, if the work of breathing is low in a patient, if NIV is not tolerated or SpO2 is not improving, you will move on to high flow nasal cannula in the chap. But if the question is talking about high work of breathing, then it is straight away intubation with a tracheostomy which is to be used. So NIV is when the work of breathing is low, when the person is able to tolerate NIV, and I would say that his respiratory muscles are not having a fatigue. You see, lots of time what happens is, our patients, they are gonna be like, what happened last year, they were not getting admission. They were sitting in their car with oxygen attached to them. Now, if the guy has sat in his car for 6 hours, 8 hours before he could get a ICU bed, his muscles are already tired. The work of breathing has been so extensive. He has been working so hard to keep himself alive that I know that the muscles will undergo fatigue. So in those circumstances, we will have to intubate those patients who are having increase of CO2. I mean, how do I know how increase of work of breathing? I'll check out ABG. The respiratory acidosis component will start coming in the patient, whereas severe respiratory acidosis will start coming in the patient. Whereas most patients, when they're admitted, they would be having respiratory alkalosis where PCO2 value is lesser. So when I'm evaluating my patient, I'm gonna do it on clinical grounds. I will check out the usage of accessory muscles. I will check out the ABG report of the patient. Initially, you have respiratory alkalosis due to carbon dioxide washout. So we can be using non-invasive ventilation for the patient. But as the CO2 values start increasing, there would be carbon dioxide narcosis in the patient, and that is when intubation would be required. Baki steroids are common. Steroids and heparin would anyway be required for the patient. So the PDF is what I'm gonna share. I mean, the steroids, methylprednisolone, dono mein hi dena hai. Heparin is to be given in both of these cases. Anticoagulation, no big deal. And when it comes to management of COVID, I mean, the only thing is slight modifications are there with respect to terminologies, like when would you admit into a high dependency unit, how would you admit into the ward per se. So I would rate this as slightly a more difficult one as compared to the previous ones, and that is what happens in the exam also. It's a mixed bag. You are gonna get citrus, like I started the discussion with the, I think I showed this on the screen and the guys were spot on. Okay sir, the answer is gonna be option number A. Sir, yes, it's a tight fitting face mask doctor. NIV जो है ना routine face mask से different होता है. And if you're having, if you have not read about oxygen administration therapy and you want a shortcut, then it is recommended that there is a very short video on my YouTube channel, oxygen supplementation therapy. You can just go through that and you would understand how do we administer oxygen to hypoxic patients. D-dimer would again be checked 48 to 72 hours. D-dimer would be checked 48 to 72 hours. Yes, Dr. Medico's FMG section, I will be doing sessions subsequently. Absolutely. Okay. So let's move on to the next one for this one. Ayushi said when to use NIV. Doctor, when this person will come to my hospital, no, and the person is having respiratory alkalosis and the work of breathing is low, respiratory accessory muscles are not tired at the movement. I will be starting with NIV, upgrading to HN, high flow nasal cannula, and the last resort would be to go in for mechanical ventilation. If in case you missed it, Ayushi, the basic point behind this MCQ is, if this MCQ said work of breathing is low, then it is NIV. If the work of breathing is high, and that's what I've highlighted, and that is in the protocol, work of breathing is low. He's written that in capital. So whenever you read a protocol per se, all those capital words are the ones which are to be remembered. Let's move on to the next one. This is a HIV positive patient who has come to me with diarrhea, crampy pain, and you very well know about common causes of diarrhea. Uh, is diaphragm paralyzed to decrease? No, diaphragm is not paralyzed. No, diaphragm will be working overtime. No, तो chest के lower part में कार्टिक गड्ढा पड़ेगा ना. There's going to be subcostal recessions present in the chest. The subcostal recessions will occur because the diaphragm will be working more than normal. So if I'm getting subcostal recessions and they have been persistent for a long duration, I know that the chap is deteriorating. Intercostal recessions, they tell me that these muscles will get tired very soon. Okay. Okay, Viplav has answered beautifully. Okay, fine. If oral cavity infections occur, do NIV be used? We can use a helmet interface. No, if it is causing too much of a problem. Oral cavity infection would mean like dental caries, or would it be like a fungal infection? If it's gonna be extensive esophageal candidiasis and he's having severe odynophagia, I'll be a little worried. In those circumstances, I'll be more comfortable maybe doing a tracheostomy in the patient. But otherwise, yep, you can use a helmet interface to make him feel more comfortable if the tight-fitting face mask with oral infection is causing pain and discomfort in the patient. Okay. Here the main concept is HIV positive patient is having an opportunistic infection and you need to pick out the happiness zone. The doctor was arrested, the patient died because of treatment. That is because they think that the doctor gave some injection which was may have been benzodiazepine and it might have caused a respiratory arrest. I mean, let's not be I would say worried about this in a perspective that if the notes of the doctor are complete, nobody can touch him, patients keep on dying, we try our best. So you just have to keep proper documentation. And I thought, in fact, now because you have raised it, I just want to say one of my doctors, he's a foreign medical graduate doctor. I wanted to put up a video of mine with him because we did a Zoom chat regarding this 302. And what he told me was, first and foremost thing is, we doctors are morbidly afraid of this 302 and arrest. That arrest is not like somebody would be put in jail. Right, first of all, and 302 will never stand. I mean, the charge sheet has to be filed in the court of law, and that charge sheet is not even filed properly by the police, even in a genuine murder case. So even murderers go away, whereas we doctors are just afraid of police. So what this guy who has actually left MBBS, he did post graduation. This doctor that I'm talking about, in fact, I will post a video with him. Okay, fine, decided now. This guy has quit MBBS. He's post graduation and he's done LLB. He has done LLB and he is now working with Bajaj Alliance. And this chap, he is also working as an advisor, medical legal advisor to Lucknow High Court. I'm a doctor I'm talking about, right? And happens to be a student of mine. And he mentioned very clearly that, sir, we doctors are very afraid of all these charge sheets and stuff like that. They can never prove it. So we just have to be bold and we have to take insurance. Coming to the question here per se, the cyst size present in a HIV positive patient with diarrhea is 1 to 2 microns. When it comes to Giardia, the size will be approximately 10 into 10 microns. First of all, if it is Giardia, the size of the cyst will be relatively bigger. And the cyst will be having either 2 to 4 nuclei. In fact, I can show the image of Giardia, which is usually given when it comes to, okay, I don't have the image of Giardia. So what I'll do is I'll just hand draw it. When it comes to Giardia, the cyst would either be having 2 nuclei or 4 nuclei. And the difference is when it comes to 2 nuclei, it is an immature cyst. And when it comes to 4 nuclei, it is a mature cyst. So first of all, yes, Viplav, you were the first one to give correct answer to this question. I will post that video. 302 charge sheet is to be filed in the court and they have to prove that there was an attempt to murder and something like that. It will never stand because if these guys are so bad that they can't even prove a real murder, how can they prove something where we were trying to do genuine good thing for the patient? So first of all, we have to remove this fear from our mind of police that, oh, police will come and then our reputation will be affected and this will happen and this will happen. Nothing will happen, sir, because you are honest, you did your right thing. You just keep your documentation correct and you hire a good lawyer and nobody will touch you. Nobody can touch you. That's the most important thing. The answer is not option number D, because the size of the cyst is important. Cryptosporidium parvum, the size of the cyst is 4 to 6 microns. And do you understand? I mean, a doctor forsaking his degrees and now becoming LLB. So you can very well understand why. I mean, why would he have decided? Answer is not C, guys. Why? Because the size of the cyst is important. It is 4 to 6 microns. Cystoisospora is one of the biggest, that is 25 to 30 microns. So my request to you guys is, if you go through the previous year questions, whether FMG ones, whether you go through the NEET PG ones, there is always a question on HIV positive patient. Absolutely, Karthik, you are spot on. You are spot on. See, when we are doing fine, when we are not being dishonest, and we are trying to save somebody's life, we don't need to be afraid. We just need to be sure with documentation, keep a good lawyer, and thoda sa badmashi wala attitude aana chahiye. Like, you know, I'll say this because I have to say this to you guys. First and second year mein, when we are in first and second year, we think ourselves to be think ourselves to be badmash. Right, we think ourselves to be you know, like the badmash of the college. So that same attitude we need to get right now also. We don't need to be bogged down by all this. We have to fight back. Okay, guys, the answer to this question is option number A, that is microsporidosis. The answer is not, though our discussion went little offbeat at the moment. The answer to this question is not gonna be option number B, C, D. It is option number A. Please go through the previous year's questions and you will be able to solve this. And well, can you comment on the drug of choice for this condition also? Yes, guys. Please comment on the drug of choice that you'll be using for management of these patients of microsporidosis. In fact, you can comment on the drug of choice for all of these. what drug would be used in a HIV positive patient who's having Cryptosporidium parvum? Yes, guys. Yes, bouncer mode is what I've already said, happiness zone. That bouncer mode is already on. In basic life support, we'll have a bouncer mode also available now. Okay. Cryptosporidium parvum. Yes, guys. Metronidazole is for Giardia. Cryptosporidium parvum, we shall be using nitazoxanide. Metro is Giardia, that's okay. For Cystoisospora, we shall be using cotrimoxazole. Can you tell me the drug that we'll be using for microsporidosis? The question is still open. Can you tell me the drug of choice for microsporidosis? And I think everybody is missing the bus. Amit, I missed your query. Can you just post it? Or Amit, you said please guide. So I missed your query. You can send me a mail at marwahmedicine@gmail. Maybe I missed the chat in between while I was writing down the data. Okay. Exactly. The drug that we'll be using for microsporidosis is albendazole. It is not to be answered as what you guys are answering. No, guys, it's not doxycycline. It's not praziquantel. It's not metronidazole. You would be giving albendazole for these patients. Very standard question on HIV positive patients. What they are gonna do is they are gonna mix up the information of some aspects of general medicine with that of microbiology in the exam. I would call it a pure medicine microbiology integrated question, and fungus and especially, I would say protozoa as a topic and fungi as a topic is what is usually neglected. Protozoa and fungi. We study bacteriology very well. Even we have gradually started studying a bit of parasitology, but we tend to neglect, especially protozoal infections, we tend to neglect fungi, and that is what they're asking right now. So if you got this question correct, great. If not, please be very thorough with it. The PDF I'll be anyway posting. This is a small, though the microbiologist will do a better job than me at teaching all this, but then I just put a small document with respect to how these cysts would be looking, and your job, homework for you guys is put in the size for each of them. This is something that they'll always ask you, because entamoeba cyst will also be quadrinucleate and Giardia cyst will also be quadrinucleate. So one difference is that they'll be yes, Ibiza, we'll be putting up more questions for NEET PG. One difference between the two would be the covering. or the physical appearance. Yes, Swaroop, I'll be coming up with more sessions also, don't worry. This is a small handout from my side to you guys. Just fill up the size, because I thought if I'll write size here also, then I'll be doing too much of spoon feeding for you guys. So please put in the size of the cyst, because when you had to solve this MCQ was easily solvable on the basis of the size of the cyst. And if you have not read that information, please go through the previous year papers so that you are able to get these questions right. And the drug of choice for them is definitely mentioned. I have CNS, Amit. What I would suggest is you can go through especially stroke, you can go through multiple sclerosis. Amit, my suggestion is just drop me a mail. I'll send you the list of must know topics from CNS. Like neurocystic sarcosis पूछता है ना, difference between neurocystic sarcosis and tuberculoma. So he'll ask you MRS, magnetic resonance spectroscopic findings. How do you differentiate tuberculoma versus the NCC? So though I've done that in rapid revision also, but what I'll be more comfortable is if you drop me a mail, I'll send you the list of the topics which are to be asked. Myasthenia gravis पूछता है ना, whether it is FMG exam, whether it is NEET PG exam, question on myasthenia gravis will always be there. At this particular point of time, what I would recommend is to spend maximum time of yours in doing MCQs. At least 50% of your time should be doing MCQs, and there you should try to work out the answer on the basis of exclusion, instead of waiting for a grand test at the end and say, okay, I scored this much in the grand test. When you are gonna be doing this on a regular basis, I think you guys are gonna be mentally charged up. I mean, the message number 2 for today: whether you have eaten or not doesn't matter, whether there is no electricity, whether it is very hot, whether you are hypoglycemic, whether you are hyperglycemic because of eating chole bhature, your performance in MCQ should still be static in a sense. Bang on the spot, you should be able to get the answers right. Nothing should mentally and physically affect you. Yes, Sachin, you're right. Lipid peak with respect to tuberculosis. The message is that whatever be your mental state, you had a fight with your boyfriend, girlfriend, whether there is some problem in the house, whether there is no electricity, you are sweating profusely, but when you're doing MCQs, you're doing MCQs. That's the main message of mine. At least 100 per day, Ravi, is what is recommended. You should try and increase up to 200, because after all, exam would be something if FMJ exam 151 session. People don't have stamina to sit for 2.5 hours. No, after half an hour we start checking our phone. So if you are gonna sit for that longer sessions, you will be able to solve it. Harsh, this happens with everybody. You are torturing your neurons. You are putting so much of information in your neurons that your neurons are crying, save me from this guy. So because you are torturing your neurons, at the moment your neurons will not respond. But when it comes to neurons, they have a lot of plasticity, as I said yesterday also. So this information will not go waste. None of this. Viplov, okay, I'll post it, the must know topics, though I've done it already, but anyway, Viplov, good suggestion. I'll post it in the group. Email address is marwamedicine@gmail.com. The group would be when it comes to I mean the telegram would be top educator. For calculations, you can avoid in FMG exam. In FMG exam, they will simply ask you that a patient came with sodium value of 120, what fluid will you be giving in the patient? So you can answer that, and meanwhile the rest of the guys can do some calculations. In this particular case, the question talks about total deficit. In fact, I have put up 2 questions on similar lines. One of them will say calculate the total deficit, and the second MCQ will say correct how much is the correction to be given to this patient in the next 24 hours. So the answer will vary. When it comes to total deficit in a patient for 60 kg female, in females the multiplication factor will be 0.5. In men the multiplication factor will be 0.6. Then subsequently what will be the desired value, and the actual value is anyway given. Patient is having hyponatremia. The actual value given in the MCQ is 120. The desired value that I want to put for this particular case will be 140. 135 to 145, no, so average is 140. So when I'm going to do the simple calculation, you will notice that the multiplication of this for the total value will turn out to be 600. The correct answer for this question, because it is saying total deficit, is 600. However, now let us modulate. If this was a male, the answer will vary. If it is a male of 60 kg, then the answer will obviously change. Then you will do like this, multiplication by 0.6. That would be something in the range of about 720. This is the total deficit. This is the total deficit. Yes, Dr. Vandana, I'll post up a message on the must do topics in the Telegram group. I'll definitely do that. Because the question is saying total deficit, therefore the answer for this question is 600. It's not 240. Now compare this with the next question. Same question, he says how much is the correction to be done in the patient in next 24 hours. The total deficit in the patient is still the same. Total is 600 milliequivalents. But if you will collect all total 624 hours, you see patient is sick for past 1 week. If patient is sick for last 1 week, it would be chronic hyponatremia. Sir, mathematics weak है, कोई फर्क नहीं पड़ता. All doctors have poor mathematics. It is simple mathematics that you need to practice for once and for all. It is chronic hyponatremia patient. In chronic hyponatremia, if you do fast correction, there will be risk of central pontine myelinosis. क्योंकि क्लाइंट को, क्योंकि पेशेंट को ऑस्मोटिक डीमाइलिनेशन सिंड्रोम हो जाएगा, तो वी विल नॉट ट्राई टू करेक्ट ऑल ऑफ दिस इन अ सिंगल 24 आवर पीरियड. Because of the risk of osmotic demyelination in the patient, everything will remain the same in this MCQ. Weight will be 60. You will still multiply by 0.5. The target value will change. How much should you increase per day? Then increase should be only 8 milliequivalents. So in this particular case, you will be multiplying this and getting a value of 240. The correct answer for this question is option number A. In FMG exam, they will simply ask you what fluid will be used for correction. In this particular case, you very well know the answer. We will be using 3% saline for this patient. But the message of this particular question is that if there is a overcorrection, okay, doctor, if there's a overcorrection, then we might have to use desmopressin in the patient, DDAVP. And if you do overcorrection, DDAVP will draw in water and that will try to bring down the sodium values back to normal values. So correction should be kept under check. That's the basic point. We want to prevent central pontine myelinosis in the patient. Harsh, as far as the planning part is concerned, I would say 50% of your time into previous year MCQs, 50% of your time into reading the main videos or the RR notes, whichever you are finding comfortable. If you're putting 10 hours of study every day, and out of this 5 to 6 are in MCQs, 5 to 6 in going through the notes, and don't try to remember everything from the notes because you won't be able to. So if you're thinking every point that is given, you will be able to remember us. It will contribute to definitely issues. I mean, in a sense that the performance will go down. So just try to focus 10 hours today, maybe 9 hours tomorrow, focus on 10 hours the next day, and you will be perfectly fine. Dr. Fadia, the issue is that people are trying only in Delhi or in Mumbai or in bigger hospitals, and nobody is going to peripheral hospitals or district hospitals. If somebody wants to lead an easy life, they can go outside Delhi and they'll be getting internship and they'll be easy to okay, you're talking about online MBBS part. This, Dr. Nadia, I'll not be able to answer at this particular point of time because then the academic part will be affected. But then the main message was that in the MCQ for sodium correction, whenever a person is having hyponatremic seizure, please read this carefully. Total deficit word is given or correction in the next 24 hours is given because the answer will vary. In chronic hyponatremia, Nidhi, in the last week, I think it's only going through the notes that will help. And in fact, most of the guys that I have talked to, they have said that in the last 1 week, I was not trying to do GTs or doing MCQs because if they will try to go or they go wrong, then I will be feeling depressed. So I thought I'll just brush up, like, finishing medicine in 1 day. It is possible. People have done that, finishing surgery in 1 day, brushing through the notes of whichever subjects you're morbidly weak in. For example, if I am weak in parasitology, if I'm weak in remembering all these fungi, I am gonna be like reading the notes of those particular topics. Or let me say in biochemistry, if I am morbidly afraid of nucleic acid metabolism, I am good at carbohydrate metabolism. Everybody is, but if I'm bad at fat metabolism, if I'm bad at nucleic acid metabolism, I'll try to do that. So osmotic, how common it is, doctor? When it will happen, relatives will come and cause mayhem. So don't wait for how common is osmotic demyelination syndrome, because it occurs because it is given in the textbook. Then I would not suggest you to try and do a total correction. I mean, that is too over ambitious for any doctor to try and get the sodium values from 120 to 140 in a range of 24 hours. I mean, this can contribute to a lot of issues. How to improve accuracy? Accuracy comes with practice, buddy. Like Farhan, good to get your message. I mean, Farhan has been my old student actually. So Farhan, the message is that when you do questions, you have to check it out why it went wrong, and it could be lack of knowledge, it could be lack of application. Lack of application is to be is to be solved. Amit says, can I watch MCQ based discussion for medicine? Yes, Amit, you need to go through previous year papers so that you can know what topics are coming. No, so at least जैसे हाइपोनेट्रीमिया पूछता है यार, हर बार कोई भी पेपर उठा लो, मतलब इलेक्ट्रोलाइट इम्बैलेंस में क्या पूछेगा, हाइपोकलीमिया हाइपरकलीमिया, उससे बोर हो गया तो हाइपोनेट्रीमिया पूछना शुरू कर दिया, जैसे हाइपरनेट्रीमिया पूछ लेगा। तो इलेक्ट्रोलाइट्स का जो टॉपिक है, वो इलेक्ट्रोलाइट्स का जो टॉपिक है वो आई थिंक द मेन वीडियो इज 2 hours. Just give me two. I am requesting, you know, if you have not gone through it, 2 hours of your entire life बोल रहा हूँ, 2 घंटे मुझे दे दो. I assure you the fact कि आपके बोले जो MCQ है वो डेफिनेटली सॉल्व हो जाएगा, बिल्कुल सही हो जाएगा. ओके जी, फाइन. फ्रॉस्टबाइट पेशेंट इज रीवॉर्म्ड एट व्हाट टेम्परेचर? तो ये क्वेश्चन मैंने इसलिए डाला क्योंकि मुझे कंट्रोवर्सी क्रिएट करनी थी, बिकॉज नाउ आई विल जूम इन एंड शो यू व्हाट हैरिसन सेज एंड यू विल ऑल से सर यू आर गिविंग अ कंट्रोवर्शियल क्वेश्चन. सो देयर विल बी सम कंट्रोवर्शियल क्वेश्चंस दैट विल ऑलवेज बी देयर. लॉट ऑफ गाइज हैव कमेंटेड इन दिस पर्टिकुलर चैट, स्पेशली 42 degrees. आई डोंट डिस्प्यूट दैट. इवन 42 मतलब कोई फर्क नहीं पड़ने वाला यार, बट द पॉइंट इज my request, Kamran, my telegram group is top educator. Otherwise, if you're not able to locate it, you can send me an email at marwamedicine@gmail.com and I'll send you the link. I have deliberately put up this question because I was getting lot of queries, sir, former NEET PG MCQ, and we have read, and in the app somewhere it is given 42 degree and you are saying 37 to 40 degree. So what should we answer in the exam? I recommend सर वीक है, होता है, हर डॉक्टर के वीक सब्जेक्ट्स होते हैं, उनको सिर्फ आपको वीकनेस को दूर करना है. ठीक है जी. तो ये दिस इज रेफरेंस ऑफ हैरिसन जो कि मैं यहाँ पे हाईलाइट कर रहा हूँ. द रेफरेंस ऑफ हैरिसन सेज दैट you should be immersing the frozen tissue by putting it in circulating water at 37 to 40 degrees for 30 to 60 degree. The correct answer for this question is option number A. और इसके बाद में अब ये नहीं करना कि you start sending messages to different faculties and sending messages to apps कि जी आपने आंसर 42 दिया है. तो ठीक है यार, मेडिकल साइंस में यही तो पॉइंट है कि मेडिकल साइंस कैन बी हैविंग वेरिएशन इन ओपिनियन. We have to be wise enough to take all that opinions and then decide कि भाई हम किसको फॉलो करें. तो हैरिसन एक ऐसी टेक्स्ट बुक है जिसको सभी फॉलो करते हैं, यूनिवर्सली माना जाता है. तो ऐसा नहीं है कि 42 पे कोई बर्न हो जाएगा, ये 42 इज अ रॉन्ग आंसर. इट्स नॉट लाइक दैट. It is simply the fact that we will have to take at least one reliable source. I've given you the reference of the 20th edition of Harrison in this case. So please इसके बाद में कोई लड़ाई नहीं करना कि जी वो XYZ ने ये बोला, आपने ये बोला, हमें समझ नहीं आ रहा. I have given you inputs, explained to you that you have to be wise enough to take multiple inputs and then decide rationally what is gonna be correct हो गया. Okay, nahi ji, I'm pretty happy at my place, and we at PrepLadder are we are having a very high strike rate for a lot of things. So chalo, Dr. Aparna, I think this is what is recommended, 37 to 40 degrees. Reference of Harrison is always taken to be superior as compared to other textbooks. So okay, Dr. Rizvi says GT was 135. See, Rizvi, the point is you need to focus on, I mean, you would have got those wrong ones also, no? So if you're getting those wrong ones, just make a list of them, no? If you make a list of whichever is gonna be going wrong, you would be knowing, okay, this went wrong because of lack of knowledge, this went because of lack of application, and some are gonna be anyway controversial aspects also. So it doesn't matter. The answer, Avinash, your internship is starting. Okay, Avinash, drop me a mail and we can have a discussion about it. We are trying to focus on the MCQs at the moment. बबलू जी, कभी भी कुछ भी याद नहीं होता है. हमें लगता है कि हम याद कर लेंगे. हम अपने न्यूरॉन्स को टॉर्चर करते हैं, तो न्यूरॉन्स को टॉर्चर करने के बाद में होता है कि हम भूल जाते हैं. बट देन योर न्यूरॉन्स आर इम्बाइबिंग दैट इंफॉर्मेशन, नॉलेज विल नॉट गो वेस्ट. डॉक्टर पीजी, सर आपने ब्लैक वाला थंब वो अपना डीपी लगा रखा है, तो ब्लैक से थोड़ा कलरफुल वाला लगाइए ताकि लाइफ इज मोर पॉजिटिव. जस्ट जोकिंग, डोंट टेक इट पर्सनली. बाकी हाँ जी, आप आरआर करो और साथ में प्रीवियस ईयर क्वेश्चंस करो ना, तो हो जाएगा. Retention is something which we all have, you know, problems with, but that retention part can be easily solved by writing down whatever points that went wrong. So don't worry ji, Let's move on to the next one. The next question talks about vitamin B12 deficiency. Hi Bablu, good evening. एंड आप डॉक्टर साहब आरआर करो, आरआर के साथ में प्रीवियस ईयर के पेपर करो, क्योंकि पहले प्रीवियस ईयर के पेपर कर लोगे ना तो यू विल गेट अ आइडिया अबाउट व्हाट आर द थिंग्स दैट एक्चुअली आर बीइंग कॉमनली आस्क्ड इन द एग्जाम. ओके जी. यस प्रहलाद, वी विल बी हैविंग एफएमजी सेशंस आल्सो. यू कैन ज्वाइन माय यूट्यूब चैनल, वहां पे भी सेशंस डालेंगे. मूविंग टू द नेक्स्ट वन. Ritvik, you can, I think morning hours should be first for MCQs because the exam is going to be in the morning hours most of the time. So because the exam is morning hours, you are fresh. I would like you to do multiple choice questions in the morning. Okay, coming to the next question, which talks about vitamin B12 and vitamin B12 deficiency. Let's look at the answers here. It's transported in the bond form to haptocorin. Well, you very well know that vitamin B12 in our body, it has to bind to intrinsic factor. But before it reaches the stomach, because you see the acid in the stomach can easily destroy vitamin B12. So to prevent this vitamin B12 from getting destroyed by the acid in the stomach, there is a special protein present. Where is this special protein produced from? It is produced from our salivary glands. Our salivary glands produce a product which is called as haptocorin. This haptocorin will bind to vitamin B12 and it will give protection from the acid of the stomach. So first and foremost, I want to tell you that 3 years of sufficient Rishabh, it's gonna be pretty a main job, no? At least finishing 3 years of MCQs, that's gonna be pretty a tough job. If you look at A, the message is haptocorin is a transport protein which is produced by our salivary glands. It protects vitamin B12 from the stomach acid, and then subsequently this complex is absorbed from the terminal ileum. Once it is absorbed, then we are having that transcobalamin thing. No, the transcobalamin thing is haptocorin. So option number A is the correct one, which was initially the answer that was coming up. The question is not correct. B says neurological features can develop in absence of anemia. Definitely yes. I mean, in B12 deficiency, you can have a macrocytic anemia. Harrison is the best book, Richa. It is macrocytic anemia and it is going to be neurological features, but you could be having neurological features also even in the absence of anemia. This is line to line from Robbins. This is line to line for Robbins, developed in absence for anemia. So you need to definitely remember this statement. I mean, this line, you know, the thought process is first anemia occurs, then neurological features. But in Robbins, this line is given. Neurological features can develop in absence of anemia. C says hyperpigmentation of the joints. So there was actually an image-based question that came in the recent exams where there was mention with respect to hyperpigmentation of the interphalangeal joints and of the knuckles in patients with vitamin B12 deficiency. In patients of vitamin B12 deficiency, you need to have hyperpigmentation. Sir, in the app, I have discussed all the previous year papers. It will hardly take 3-4 days of your time, but at least for medicine and surgery, go through all these previous year questions so that you will know the topics from which the questions are coming. Hyperpigmentation of the interphalangeal joint. Hyperpigmentation of the knuckles is a common presentation that is seen in people with anemia. Apart from this, you would also be having atrophy of the filiform papillae. Once those filiform papillae are gone, you would be having that bald tongue that would be developing in this patient. The skin would also look slightly yellow, so lemon yellow tint of the skin. I mean, I'm talking about cutaneous manifestations of B12 deficiency. The dermatological or Ritvik, it's all the MCQs. NEET, INI-CET, hardly यार 2 दिन का काम है, हो जाएगा, करके देखो. Lemon yellow tint, filiform papillae का atrophy, hyperpigmentation of the interphalangeal joint, it can cause, yes, please remember this hyperpigmentation can mimic Addison disease की hyperpigmentation. I have described Addison disease in Osama bin Laden in the app, right? Osama bin Laden was suffering from primary Addison disease, autoimmune. The hyperpigmentation of B12 deficiency can mimic the one that is going to be seen with vitamin B12 deficiency. This is a reversible hyperpigmentation. So lots of time in especially hardcore vegetarians. In hardcore vegetarians, vegans who do not even consume milk, you will find B12 deficiency, anemia. I mean, there would be complaints of paresthesias and anemia. and hyperpigmentation, which is gonna go away. Option number C is correct statement. The correct answer for this is D, because क्या होगा, B12 deficiency will cause peripheral neuropathy. If there's gonna be peripheral neuropathy in the patient, this is gonna contribute to development of paresthesias. भाई most जो B12 deficiency वाले patients आते हैं, they are hardcore vegans, और उनकी complaint क्या होती है? उनकी complaint होती है कि सर हाथ पैरों में से ना heat निकलता रहता है. I mean, it's not actually heat coming out from the fingers and toes. It is, people will say like that, you know, in Hindi. So basically the point is that there's gonna be paresthesias that are gonna be present, tingling sensation which is gonna be present in these patients. So the basic concept that I want you to remember is peripheral neuritis is going to contribute to paresthesias, that is going to be tingling sensations which is going to be present in the extremities. And another feature that you will always notice is because इनको peripheral neuropathy होता है, तो he will always write absent ankle jerk. Because of peripheral neuropathy, he will say absent ankle jerk with Babinski sign. This is itself a MCQ. Absent ankle jerk with Babinski sign present. The Babinski sign is present because in these chaps there is going to be demyelination of the corticospinal pathway. So Avinash, earliest is going to be paresthesias because of the nerve involvement in these patients. The basic point is that because of this peripheral neuropathy, you could be having absent ankle jerks, but Babinski sign would still be present, and that Babinski sign would still be present in this chap because of the corticospinal pathway involvement. The correct answer for this would be option number D. And vitamin B12 deficiency से diabetes हो सकता है. नहीं डॉक्टर साहब, बड़ा highly unlikely है. It is कि diabetes दो disease एक साथ होंगे. So I would say a separate etiology for the same. The correct answer for this question would be option number D, and vitamin B12 deficiency and subacute combined demyelination is usually asked. So we definitely need to solve this. Okay, moving to the next question for these patients. Consumptive hypothyroidism, pretty straightforward one. This talks about okay, if I read out the options, then the answer will become very obvious for you. हाँ जी मयंक, दोनों अपर मोटर और लोअर मोटर के फीचर होंगे. Yes, that is the point. B12 डेफिशिएंसी वाला जो डिजीज है उसमें एक ही पेशेंट में लोअर मोटर और अपर मोटर के फीचर होंगे. बाबिंस्की साइन क्यों हुआ? क्योंकि स्पाइनल कॉर्ड इज गोना बी हैविंग अ डीमेलिनेशन ऑफ द कॉर्टिकोस्पाइनल पाथवे, एंड एंकल जर्क एब्सेंट हो जाएगी बिकॉज ऑफ द फैक्ट कि इसको पेरिफेरल न्यूराइटिस का कंपोनेंट हो जाता है. सो द बेसिक पॉइंट इज लोअर मोटर अपर मोटर के जो फीचर है वो एक एमियोट्रोफिक लैटरल स्क्लेरोसिस में होते हैं, एक फ्रेडरिच एटैक्सिया में होते हैं, और विटामिन B12 डेफिशिएंसी होते हैं. दो डिजीज जो कि एग्जाम में अगर लोअर मोटर अपर मोटर के फीचर दिए हुए हैं तो फ्रेडरिच एटैक्सिया कंसिडर करना होता है, मतलब एमसीक्यू वाइज बोल रहा हूं, सब एक्यूट कंबाइंड डीमाइलिनेशन को कंसिडर करना होता है. यस गाइस, consumptive hypothyroidism would be seen with excess intake of iodized salt. Okay जी, fine. तो बेसिकली आप लोग जो हैं वो ये बोल रहे हैं कि सॉल्ट ज़्यादा खाने की वजह से उसको हाइपोथायरॉयडिज्म हो जाएगा. तो हाइपर भी तो हो सकता है ना यार. You see, the basic point is a chap can be having excess of iodized salt, and that excess of iodized salt can cause a Jod-based effect also. It can otherwise be, I mean, even in this situation also correct, no? Excess intake of thyroid hormone is easy, that is thyrotoxicosis factitia. If a person is taking excess intake of iodized salt, it can cause a Jod-based effect. No, if there's going to be Jod-based effect in a patient, that can contribute to hyperthyroidism manifestations also. Sir, this will contribute to hyperthyroidism. If somebody will take more of iodized salt, iodine trapping can increase, and that increase of iodine trapping can contribute to development of Jod-based effect. The question is based on exclusion. You will be getting questions in the exam where you will have to apply logic. The answer to this particular question is not option number B. Why? Because that is thyrotoxicosis factitia. You know, the guy is consuming contaminated beef, poor quality beef, which is having the thyroid gland of the animal. Like when they prepared this beef, the thyroid of the animal was also pounded in the beef, and the person is consuming this tainted beef, he'll end up with the development of hyperthyroidism. Option A and B contribute to hyperthyroidism. If you're saying option number C, Putin sent his troops to Chernobyl when his elite commando unit went through that forest. They kicked up that radioactive dust consumption, radioactive exposure. What will it cause to those Soviet soldiers in future? It will cause development of thyroid cancer. The answer cannot be A, B or C. as radiation will contribute to development of a thyroid cancer in future. When the troops of Putin have driven through Chernobyl and they've gone through Chernobyl, right? They kicked up the radioactive dust, and that has resulted in, I mean, the guys becoming sick. This question is a tricky one. Lots of time, especially if you are going to be sitting for NEET exam, there are going to be questions where you will come out of the examination hall and say the answer to this question is A or B, as you guys are doing right now. But the basic point is the what looks to the eye will not be the answer. Lots of tricky questions will always be put in the exam, and this is one such example of it. Now I will give you the logic behind it. It's papillary cancer of thyroid, no? रेडिएशन एक्सपोजर के बाद में पैपिलरी कैंसर ऑफ थायराइड हो जाता है ना, तो रेडिएशन एक्सपोजर के बाद में पोटेशियम आयोडाइड के टैबलेट्स खानी होती. Consumptive hypothyroidism occurs because of release of a thyroid hormone inactivating enzyme by some cancers. Consumptive hypothyroidism is a misnomer. When we read consumptive, we think we are talking about goitrogens. We are thinking about cabbage, we are thinking about cauliflower, we are thinking about vegetables which are going to contribute to hypothyroidism in an individual, whereas surprisingly or shockingly, what is happening is that there are some tumors which are destroying the thyroid hormone. The tumor will produce an enzyme, that enzyme will inactivate the thyroid hormone. Thyroid hormone will be produced from the gland. But unfortunately, there's going to be a tumor which will contribute to the destruction of the thyroid hormone. The correct answer for this is option number D. Guys, I had to give you at least one question that you will not be able to solve. You have been able to solve all the previous ones, no? So at least please give me the benefit. In case you got this wrong, don't be sad. Doesn't matter. This will always happen in the exam. I'm trying to mimic exactly the way they will put it in the exam, that we will think, okay, this is an answer, will turn out to be a googly, so I'm going to call it a googly here. You guys playing cricket, you very well understand the ball the swings the other way around. So there is always going to be Dr. Razvi, that's a problem that happens with everybody. So keep on practicing, keep on noting down those next best steps, and you will be doing much better. So with the practice, you will be able to do it. Neha Kumari says nothing is going inside my mind. Dr. Neha, this happens with everybody. कि माइंड में कुछ जा नहीं रहा है, समझ नहीं आ रहा है, क्योंकि हम अपने ऊपर ना पीयर प्रेशर से हम क्या करते हैं, हम कहते हैं यार जैसे मॉक टेस्ट दे रहे हो आप, राइट? तो एवरीबडी इज लाइक आई शुड बी गेटिंग 140 करेक्ट. टेस्ट देने से पहले ही डिसाइड करते हैं भाई मेरे 140 सही होने चाहिए, 150 सही होने चाहिए. जब आप when you go into a test with a preset notion, I have to get these marks, you are putting undue pressure on your brain, the performance will automatically come down. So what you have to do is take this test with an open, relax बैठो यार, जैसे अभी बैठे हो ना, आप मेरी बात सुन रहे हो ना, कुछ खा भी रहे होगे, पानी वानी पी रहे होगे, चाय पी रहे होगे, कॉफी पी रहे होगे, समोसा खा रहे होगे, whatever you're doing. The point is try to give exams in a different frame of mind, in a sense कि थोड़ा relax होके पेपर दो और उसके भी permutation combination बनाओ. What is the permutation combination? Permutation combination number 1 is don't sleep one day before giving a GT. पूरी रात मत सोना और फिर GT देना. अगली बार क्या करना, sleep well and then give a GT. Then don't eat anything, try giving a GT. Try those permutation combinations and gradually make your mind so rigid that कुछ भी हो जाए, खाया पिया सोया पानी पिया नहीं पिया कुछ नहीं पड़ा, क्वेश्चन फिर भी करने हैं, प्रैक्टिस करोगे तो हो जाता है. This was a difficult one, buddy. The point is the thyroid hormone is getting inactivated by enzymes which can be produced by colon cancer, basal cell carcinomas and cysts per se. So I would not suggest you to be too much worried in case this went wrong. I mean, this is you can eat anything. Yeah, yes, Poonam, you're perfectly right. I mean, I did not expect you guys to get this one right. I mean, I should be given a benefit of at least getting one question wrong from you guys. And we now move to another one in which consumptive basically means thyroid hormone use ho gaya na. Dr. Jakhad, what is happening is that there is a destruction, consumption of thyroid hormone. The enzyme is destroying it. I mean, जो भी बन रहा है ना उसको खा रहा है ना. The enzyme is eating up all the thyroid hormone or whatever is being produced or a part of it. That's why we're calling it consumptive. Okay. Aparna, that will happen. Which of the following congenital heart disease will be having total mixing and equal concentration of oxygen in all the chambers of the heart? The line diagram for all the fours I'll not be making, but yes, I think because it's a repeat question, the guys are getting it correct. So I'll be giving a line diagram for it. The line diagram is like this. Deoxygenated blood came in the right side of the heart, went from RA to RV, went into the pulmonary artery. The pulmonary artery is going to pack it off to the lungs. From the lungs, what will happen is that there is going to be abnormal blood vessels which are going to be sending this blood back into the abnormal blood vessel is going to send the blood back into the right atria. In this particular chap, the pulmonary veins are not developed. There is a abnormal pulmonary venous connection. So what is happening in this chap is that oxygenated blood is entering into the right side of the heart and the deoxygenated blood also. Now see what happens. Whatever blood is present in this chamber that I am mentioning as 1, the same blood, the mixed blood will be going in chamber number 2. So oxygen concentration in RA and RV will be same. These chaps can also be having a patent fossa valis. So this mixed blood will also be going into the left atria, that is in the third chamber also the same blood is going. And the same blood will then be flowing downwards. The same blood will also be flowing downwards into chamber number 4. This particular condition that I have made before you, what is basically happening is that in all the chambers of the heart, RA is pushing blood into all the chambers. RA is the determinant of sending mixed blood into all the circulations. The correct answer for this one, a repeat one, is TAPVC, that is total anomalous pulmonary venous connection. In all others, there will be a definitive central cyanosis present. In fact, TGA and tricuspid atresia line diagrams are made in the app, and if you go through the previous year papers, I made line diagrams for all of these conditions. But because this is a condition or this is a discussion where I have to mainly focus on I mean, for people saying tetralogy of Fallot, please appreciate this is right to left shunting ना यार, ये तो ऐसे ही बाहर हो जाता है. क्यों? Because tetralogy of Fallot में क्या होता है कि right ventricle का जो blood है वो left ventricle में जा रहा है via VSD, and that's gonna be a deoxygenated blood. तो लेफ्ट और राइट वेंट्रिकल का जो चैम्बर है वो डेफिनेटली कभी भी सेम लेफ्ट और राइट वेंट्रिकल का ऑक्सीजन सैचुरेशन सेम नहीं हो सकता. इन टेट्रोलॉजी ऑफ फैलर, ट्राइक्यूस्पिड एट्रेसिया, टीजीए सभी में ही क्या होगा कि द ऑक्सीजन सैचुरेशन इन डिफरेंट चैम्बर्स विल बी डिफरेंट. तभी तो उनको बोलते हैं ना मिक्सिंग डिफेक्ट. बट एक ऐसा मिक्सिंग डिफेक्ट वेयर आरए विल फीड ऑल अदर्स. आरए का ब्लड आरवी में गया, आरए का ब्लड एलए में गया, एलए से एलवी में गया, सभी में सैचुरेशन बराबर होती है. वो टोटल एनॉमलस पल्मरी वेनस कनेक्शन होता है. यस सर, यू आर डूइंग ओनली आरआर. सर प्रीवियस ईयर क्वेश्चन भी कर लो. मतलब आरआर तो 16 घंटे का है, तो 16 घंटे मतलब 2 दिन यार. मतलब 8 घंटे आज पढ़ा, 8 घंटे आज पढ़ा, तो खत्म. मतलब थोड़ा ज्यादा ही शॉर्टकट नहीं लगाओ ना. थोड़ा प्रीवियस ईयर क्वेश्चंस करो, थोड़ी टेस्ट सीरीज है उसको करो. थोड़ा मतलब दो ना 40-50 घंटे तो दो ना सर मेडिसिन को. तो यस, यू आर डूइंग राइट सर बाय डूइंग रैपिड रिवीजन. बट माय रिक्वेस्ट टू यू इज दैट 16 आवर्स is peanuts for this Herculean effort. I mean, it's your career at stake ना. तो भाई जान लगा दो यार. आप ये बोलो सर, आप बस बोल दो करना क्या. तो मैं लिस्ट बताता हूँ. आरआर करना है, प्रीवियस ईयर पेपर करना है, टेस्ट सीरीज में जो पेपर्स डाले हुए मैंने उनको करना है, फिर उसके बाद कस्टम मॉड्यूल्स करने हैं. आई विल गिव यू अ लिस्ट, राइट, एंड यू नीड टू से सर आपने बोल दिया हो जाएगा, राइट. ओके, fine Lavanya, I'll be speaking in English. What these guys were saying was what should be done for the exam. So I said I'm going to give you a task, and the thought process of yours is, sir, you said it, I'm going to do it. So 16 hours is something which is I would say you need to put much more hours beyond that, and try to go through some topics like electrolyte imbalance, epilepsy, right, ECG and arrhythmias. They'll hardly take few hours, but your performance will increase. The next question says which of these will be delivering the highest concentration of oxygen. We have a non-rebreather mask present here, and we are having a venti mask which is present here, and I think all of you are aware of the fact that the FiO2 that you can Yep. The point is, yes, Jod-Based effect. Sir, वो Wolff-Chaikoff होता है ना, Aditya, that is Wolff-Chaikoff effect. You have already, Bhavik, you would have completed lot of subjects by this time, no? If you completed 10, 12, 12, 15, उसका तो revision कर ही सकते हो ना, बाकी classes चलता रहेगा. Okay, fine. So dedicate few hours separate for revision. The basic point is you need to give a maximum concentration of oxygen to the patient with a venti mask. You will be doing it something in the range of about 40% or so. With a non-rebreather mask, you can go up to 80%, but with the high flow nasal cannula, you can go up to 100%. So the correct answer for this question would be option number beta. Option number B is the correct answer. High flow nasal cannula would go up to, sir, it's a range, no, 21 to 100%. for a non-rebreather mask. If in this MCQ HFNC was not present, then answer will be D. The name of the Telegram channel, Neeraj is Top Educator. Otherwise, you can mail me at marvamedicine@gmail.com. Yes, so the correct answer for this one is option number B, guys. High flow nasal cannula. If this was not present, then the standard answer of non-rebreather mask would be required. NRBM is what we recommend for moderate course of COVID, and HFNC is to be recommended after NIV in a case of severe COVID. Okay, let's move on to the next one. The question talks about a kid. She says कि बच्चा रात को रोता बहुत है जी. And the kid cries a lot at night, and she's pointing to some lesions on the legs of the child and on the tongue. And he says, what could be the lesions? Option number C is nasal prongs. No, ये तो easy था यार. Nasal prongs. No, nasal prongs will be delivering hardly 21 to 40% oxygen. No, because they would be present only at the tip of the nose. No. Nasal prongs are going to be only at the tip of the nose, so you won't be able to deliver much concentration of oxygen. With venti mask, you can go up to 60%. No? It's going up to 40 to 60%. Yes, PDF will be there, sir. I'll post it in the group, or I can send it across to you by mail also. Okay, moving on to the next one. She says, "बच्चा रात को रोता बहुत है," and points to lesions on the leg of the child and on the tongue. Okay, जी. Cries a lot. Yes, I'm waiting for your answers here. PDF will be present in the Telegram group, or you can mail me, sir, at Marwah Medicine, and I'll be solving it for you. Vitamin, I'm getting a C here. Okay, let's work out vitamin E deficiency. Vitamin E deficiency, what does it cause? It causes 1A acanthocytes. So is there any mention of any RBC defect in this case? Then it can cause ataxia. So is there any mention of ataxia in this case? So definitely not. For people saying E, the answer is not so. What you can see in this case is the child cries a lot. If the question said child cries a lot at night, then I could have thought in terms of nyctalopia. But there is no mention of any child crying a lot at night. There is no bitot spots which are given. So I can easily rule out two options in this question. I'm left between B versus C. I mean option number B versus C. Job in hand. Nitin, with job, I would suggest that if you can, somehow adjust your duties and cut down on your working hours, then study will be possible. Otherwise, you will be too exhausted to study. You understand. Once you come back from work, mental pressure of work is too much nowadays. So it's little difficult to study. Sir, what are you seeing in this case is simply some kind of bleeds. No. What you are seeing in this case is bleeds. Okay. Can you tell me one of the early manifestations of vitamin C deficiency? I'm not going into the answer at the moment. I'm getting B, option B versus D. So I mean that vitamin B, vitamin C deficiency would come up. My point here is, my question to you guys is, can you tell me one of the early manifestations of vitamin C deficiency? Just comment in the chat box, vitamin C deficiency manifestation. One of the early manifestations of vitamin C deficiency. Yes, Avinash, very good. That's a good one. Okay, I'm getting a D as an answer for this particular question also, even at this particular point of time. Can you just comment in the chat box? Gum bleeds. Okay, I wanted you to be very clear. The earliest manifestation of vitamin C deficiency is not gonna be gum bleeding. The earliest manifestation is perifollicular bleeding. Sir, gum bleeding तो बहुत देर से होता है. गम ब्लीडिंग बहुत देर से होता है. वो जो क्लासिकल केस डिस्क्राइब्ड है ना जेम्स लाइंड वाला, कि वो देयर वाज अ शिप कमिंग फ्रॉम ब्रिटेन टू इंडिया एंड दे वर कमिंग बाय केप ऑफ गुड होप एंड दे डिड नॉट हैव दैट फ्रेश फ्रूट्स. तो वो गोरे जो आ रहे थे इंडिया में, I mean vitamin C was one reason why goras could not reach India, otherwise they would have ruled us longer. They would have come to India earlier. So those Gora people, they ran out of vitamin C and then they started having that gum bleeding. The earliest manifestation is perifollicular bleed, that is hair follicles में bleed होती है. So what this child here is having presence of bleeds. These are the bleeds which are present, and even tongue पे देखो ना, ये जो black spots हैं, these black spots which are present on the tongue is again bleeds which are present. I mean it's not perifollicular obviously, because that would be with respect to the extremities. The basic point is that this child cries a lot. Why does he cry a lot? Because the child would be having subperiosteal bleeding. So whenever you will make the child walk, or whenever you will touch the legs of the child, he will start having manifestations of, he will howl in pain. Subperiosteal bleeding. This is a 2-year-old child, maybe exclusively cow milk fed. he is not being given supplementary foods. So the child will end up with manifestations of vitamin C deficiency. That vitamin C deficiency is early manifestation is not gum bleed. It is perifollicular bleed and some periosteal bleeds that you usually see in pediatric age group. That gum bleeds is definitely gonna be subsequently. The correct answer for this question is option number Bombay. And nutrition is again one topic where sir, the question that I've discussed you is a pure FMG slash NEET PG kind of a question. I mean, I don't think so that nutrition as a topic or this question should go wrong, whether it's a FMG exam. I mean, I don't know why the differentiation is there, because questions of FMG are asked in NEET PG and NEET PG in FMG exam. The examiner body is the same, no? So they will obviously, put some difficult ones in NEET PG like consumptive hypothyroidism or maybe some things like pulmonary artery hypertension. Reason for pain, Vandana, is subperiosteal bleeding. No, periosteum is the pain sensitive structure in the bone. The child will keep his legs in a frog leg appearance. आप ओपी घई पढ़ो सर. ओपी घई में उसने क्या बोला है कि स्कर्वी वाला जो बच्चा होता है, विटामिन सी वाला बच्चा, he will keep his legs in a frog leg position. Why? Because ये मान लो उसका जो bone है, this is the bone of the child. I'll just make it here. This is the bone of the child. Over the bone will be periosteum, and below the periosteum there is gonna be a bleed present. This bleed will lift the pain sensitive structure in the bone. When you would be having stretching of the pain sensitive structure in the bone, there's gonna be excessive pain. That is the reason why the child will be crying. The correct answer to this question is option number Bombay. And again, nutrition as a topic, please read it. Yes, Harsh, Lakhanpal, you're perfectly right. Pseudo paralysis, frog leg appearance of the children. And I hope it's clear to everybody that gum bleed is something which is a very late manifestation with vitamin C deficiency. You rather get these initial manifestations here. So answer for this question is Bombay. Moving to the next question, please. Yes, Utkarsh, you're perfectly right. A pseudo paralysis, frog posture. सर विटामिन से रिलेटेड तो आई थिंक न्यूट्रिशन वाला कंपोनेंट पीएसए में भी कवर्ड है, बायोकेमिस्ट्री वाले भी कराते हैं. इट्स जस्ट दैट विटामिन सी का थोड़ा जो मैंने पॉइंट्स बोले, दैट आई थिंक यू शुड बी डूइंग लिटिल इंपॉर्टेंस. Yes, Dr. Mohammed, GI tract is well covered in surgery, so I'll not rate that as a very important topic for medicine perspective, because you're reading GI Pute Chegar in pathology, then in surgery. So, I mean, medicine, I don't know why you want to read it. Let it go. Infections, yep. Fungal infections, parasitology, they love to ask it. Yep. Moving to the next question, he says Gottron sign would be seen in, so you very well know that we're talking about dermatomyositis. Option number B in this question is gonna be heliotrope rash. That's gonna be erythematous rash around the eyes, rash on the sun exposed. That would be the V-neck appearance, right? Over the anterior neck, and then rash over the shoulders would be shawl sign. So you just had to pick up the question by exclusion. Gottron papules is what you encounter on the knuckles, right? We read two things. One is Gottron papules and second is Gottron sign. The Gottron papules will be seen on the knuckles. Today we also discussed that if a person is having hyperpigmentation of the knuckles, apart from Addison disease, vitamin B12 deficiency in the hyperpigmentation must always be considered. A spot on answer to this question is A, erythematous rash over the elbows and the knees. Let's move to the next one. A patient presents with bronze discoloration of the skin, gait ataxia in coordination with severe pallor. So a lot of things coming up. One of the key words in the question is bronze discoloration of the skin. There's CNS manifestations. There's an anemia component coming up. And then the chap is having no organomegaly, but there is an elevated serum iron, serum ferritin. There's a bone marrow picture also given. So I'm waiting for your answers for this one. Yes, the previous one was relatively an easy one. Let's look at what is your thought process with respect to the current question per se. Vitamin B12 and vitamin C are ones that I think, and vitamin D in pediatrics is more than sufficient. Okay. Nitin, I would suggest you to first go through RR, and it's 16 hours, and then previous year questions in medicine would take another 2 days. So at least 4 days, 8 to 9 hours will be required plus MCQs. So a lot of effort to be put up. Okay. Moving to the next question. In this particular case, we are having a bronze discoloration of the skin, I'm getting A versus B versus D. Secondary hemochromatosis. Secondary hemochromatosis is seen after giving blood transfusions, no? I mean, it's gonna be recurrent blood transfusions. And are we having any recurrent blood transfusions history in this MCQ? So I don't think so that you should answer as D for this particular question, because there is no history of any packed RBCs or blood transfusion given to this question. I'm still getting D as in the chat. Recurrent blood transfusions cause secondary hemochromatosis. Now let us look at option number A, that is primary hemochromatosis. Primary hemochromatosis would be having extra iron in the body, so serum iron will be elevated and serum ferritin will also be elevated. But along with elevated ferritin and iron, there are bound to be other features also. I mean, other features that you would be encountering in hemochromatosis would be specifically a development of organomegaly. In the MCQ, there is no organomegaly given. There is no hepatomegaly given in the question. You can see it is saying there is no organomegaly noted. More importantly, in a guy with primary hemochromatosis, would you be having CNS features? Do you read CNS features in a patient of primary hemochromatosis? The answer is no. Rather, in primary hemochromatosis, in the CNS part, what you read is damage to the pituitary. The damage to the pituitary will cause gonadotropins to be lesser, so LH and FSH values are lesser in patients who are suffering from primary hemochromatosis. You had to work out this question on the basis of logic and the peripheral smear and the bone marrow finding given. You can see Pappenheimer bodies, all those blue spots implies it is iron deposits inside the RBCs in a ring form. This is definitely not, I mean, one in the question, if they have given you an investigation, then that investigation should be given a due respect. I mean, do you read about any peripheral smear or bone marrow finding for hemochromatosis? No. So first and the foremost, when you're reading this question, you should be asking yourself that, okay, this question looks like hemochromatosis in the first 4 lines. The first 4 lines of the MCQ look like hemochromatosis, but if you read the subsequent part, he says bone marrow finding. Bone marrow, do you read bone marrow with hemochromatosis? No, you don't read about it. Do you read about CNS manifestation? So yes guys, bronzing of the skin. ब्रॉन्ज डिस्कलरेशन तो आयरन की वजह से है ना यार, मैंने ब्रॉन्ज डायबिटीज नहीं बोला ना, ब्रॉन्ज डिस्कलरेशन ऑफ द स्किन प्रेजेंट है. So bronze discoloration of the skin can be seen with excess iron deposition, that can be seen in sideroblastic anemia also. The correct answer for this question is option number Bombay. If you have answered D, the recurrent blood transfusion will rule it out. If you are answering C, pulmonary hemosiderosis, then this should be having a triad. In fact, one of the common problems that you encounter in pulmonary hemochromatosis would be pulmonary hemosiderosis would be hemoptysis in the patient. And this hemoptysis can be very less, so the blood will remain in the lungs. It will be taken by the alveolar macrophages, and once it is taken by alveolar macrophages, they will become iron rich. So hemoptysis is one of the presentation in pulmonary hemosiderosis, and this blood then, the alveolar macrophages will take it up. So that's why we have this hemosiderin deposits. The second feature is hemosiderin laden alveolar macrophages. This information that I've written was not given in the question, so that is why option number C has been ruled out. You are left between primary hemochromatosis versus sideroblastic anemia. CNS manifestations, sideroblastic, again iron, no, iron can cause damage to the cerebellum. Transfusion can have an allergic response. Yeah, Navneet, lots of transfusion reactions can occur. The entire list is described with respect to. There's an entire list that is described with respect to transfusion reactions in transfusion biology section. So you can go through that, and I've described the transfusion components in this one. Avinash, the answer to your query would be iron causing problems with the cerebellum of this chap. Arnab, yes, should be, but not always. Sideroblastic anemia may not have a presence of a splenomegaly. There are various variants, so your tag of saying that splenomegaly should be present would be, I would say, less important. And more importantly, I would say, the most important statement, Dr. Arnab, here would be from my perspective, if I'm having a laboratory investigation telling me in my face that there is iron deposition with respect to bone marrow, then I would give it a little more importance as compared to the organomegaly part. Because you are right in saying, spleen could have been there, it was mild splenomegaly, I might have missed it. So I can ascribe that to error of judgment on my part. or maybe a wrong technique on the part of mine that I was not able to pick up the splenomegaly component, right? So instead of relying on the experience of a doctor, it's more of evidence-based medicine as we say nowadays. So the answer for this question would be option number B. Yes, Raghu, you're right, and that's what I've explained. I mean, suppose if I'm not picking up the mild one, then there's a high probability. Yes, Sita is fine. Sita is fine, and we may not have a splenomegaly in all cases of sideroblastic anemia, especially if it will be occurring following any drug intake, then it would be especially highly unlikely. Okay, moving to the next one. A repeat question with a twist. This lady is having a past history of stroke, and she gives you this complaint that doc, there was severe pain in my left hand and arm while washing utensils, and in the left foot on splashing of water. So there are sensory complaints. I mean, he's talked about stroke, and then he's talking about this sensory complaints present in the patient: pain in the left hand, pain in the left foot while with splashing of water. There's no motor deficit or a speech deficit, so this is a pure sensory stroke. When I say pure sensory stroke, it means that the damage is at the level of the internal capsule. It's a subcortical stroke occurring in this chap. Yes, guys, I'm waiting for your answers for this particular question. It's a pure sensory stroke. This would be Dejerin-Rusi. Yep. I can rule out option number D for this case because this is anyway related to hearing, so I can rule out option number D. Okay, fine. So I'm having a A and a B and C also. So let me just write short forms here and try to remember it. It is VPL, VL and VPM. Well, let's try to knock some sense into it. When it comes to VPL in a patient, this is mainly gonna be having a somatosensory input. Now when I say somatosensory input, what I mean by somatosensory input will be this somatosensory input will be coming from two areas. One is going to be the lateral spinothalamic pathway. So you can understand that pain and temperature, because we were talking about water splashing on the face, so it could be cold water or hot water being used while washing of utensils. That might have caused a problem. And apart from this, also the information is coming by the medial lemniscus. You need to understand, I would say this question is based on a combination of medicine and anatomy. When it comes to VPL, no, तो medial lemniscus में एक तो P से ना, P से यहाँ पे जो आ रहा है, that is proprioception and pain. When it comes to VL, VL is related to balance, ventrolateral. इसको input कहाँ से आता है? तो the input for this comes from the cerebellum, and the question is not dealing with any balance issues. If you're saying VPM, yes, the VPM input will be coming from the trigeminal nerve. Because the input will be coming from the trigeminal nerve, the problem will be with respect to the face. So a lot of you were initially saying option number C for this question. Why C is not the answer is VPM, the input is from the trigeminal. The problem is not on the face of the patient. The problem is in right arm and in the left arm and in the left foot of the patient. So what we are talking about here is pain coming up, proprioception issues definitely coming up. The correct answer for this question is option number A. It's a pure sensory stroke. It is just the fact that you had to relate this with a bit of anatomy in this particular case. In the exam it was simple. He just gave you sensory stroke. He said where is the lesion present, so it's a subcortical stroke in a patient. Most guys have answered either option number A or option number C. As I told you, for VPM you need to remember it's a trigeminal nerve input that would be mainly involving the face. Face is not involved in this particular case as is present on the history. So the answer for this question would be option number A. Topic thalamus to be, I mean, if you got it correct, great. If you did not get it correct, then I would request you that anatomy discussion anyway happened yesterday. So you can just open your notes and have a look at the thalamus and the various inputs that come into the thalamus per se. And anyway, I mean, we always read pain and temperature relaying into VPL. So I would say that the manifestations are fine. It's a pure sensory stroke in a patient. Okay. Yep. So most guys have got this one correct. Good job. Let's move on to the next one. Doc, my job is to make you practice. I have given you easier ones also. So some will be obviously ones which will cause problem. You will have to analyze. Remaining ones will be easy ones. Okay. Okay, great. Moving to the next one. Which is not correct about the management of venous air embolism that is developed during hemodialysis. In hemodialysis, you are taking a vascular access. Whenever you take a vascular access, incidence of air getting sucked in is definitely a big probability. Anemia of chronic disease is normocytic, normochromic, Rashesh, Vicaria. It is normocytic, normochromic first. Chalo, koi nahi. Fine. Moving on to the next one. Vascular access is taken here, and we are having an air embolism occurring in the chap. And he says which of the following is not correct in this case. So you will immediately turn the patient to the left side. Yep. In any patient who's having air embolism, what you need to do is turn the patient immediately to his left side, and then what you will do is, like if this is the hospital bed, on one side is the head end and the other is the foot end, so you will depress the head end and elevate the foot end. What you will do is a Trendelenburg position, which will cause the air bubble to move away from the pulmonary conus. This is the pulmonary artery area. Our objective is to use gravity, and our objective is to use position to move the bubble of air. This is the bubble of air. I want to move it away from the pulmonary conus because I don't want it to land in the lungs of the patient. So two things should be done. The moment you suspect air embolism, that is BP of the patient will crash, turn the patient to left and depress the head end of the patient. If you look at the options here, turning to left is fine. That's a standard step to be followed. But this word reverse Trendelenburg is a problematic issue that will favor the clot. That will favor the clot going into the pulmonary conus. So this is the answer to this question. You will give hyperbaric oxygen therapy because this simply increases the amount of dissolved oxygen in the body. If you increase the amount of dissolved oxygen in the body, it is going to contribute to, helping the patient tide over the crisis. And I already discussed that mixing of blood and air in the heart. Air has no business to be in the heart. The thrashing, the movement, to and fro movement of the bubble or bubbles in the heart will contribute to development of mill-wheel murmur. So the answer for this question is Bombay. We just need to understand the positional aspect here. Any chap having a air embolism, the BP crashes, what we are supposed to do is turn him to left and a Trendelenburg position. Answer to this is Bombay, and the diagram here represents the position of the bubble which should be kept away from the pulmonary conus. Okay. Doc, if you answered A for this, then that would be the first step for management of this patient. If the question said no first step, then it would have been A. Okay, moving to the next one. So in the exam, you are definitely going to get one question on meningitis. Yes, emergency medicine. Yes, transesophageal echocardiography and Doppler can be done in these patients. True. Moving ahead to the next question. We have this 10-year-old kid, and this child is having fever for 2 days, irritability and poor oral intake. The kid is non-cooperative, meningeal signs are noted. So we are having a child with a CNS infection. The history is of 2 days. So I'm suspecting either a bacterial or a viral etiology. The lumbar puncture shows an increased opening pressure with 10 lymphocytes. CSF sugar is about 60, capillary blood sugar is about 80. So you very well check it out because CSF sugar should ideally be at least 2/3 of the blood sugar. If you look at the value here, 60 by 80, this would be about 75%. So CSF sugar in the patient is normal. The culture report is awaited. He says which of the following is a likely presentation. For people saying pneumococcus, if you're saying D, the pneumococcus should be having neutrophils. Are there neutrophils in the question? No. For people saying D, sugar should be low. Is the sugar less? No, it is 60. I worked it out mathematically, man. The blood sugar is 75% of what it should be. If it is less than 2/3, then we consider it as hypoglycorrhea. Proteins are elevated, that is okay, but only mildly elevated. No, normal is 15 to 45, this is 50. This is definitely not a case of bacterial, but is a case of viral meningitis. Why I'm saying viral meningitis is because there are lymphocytes in the CSF, man. When you have lymphocytes in the CSF, you cannot have a bacterial etiology. For people who are still commenting as B, please remember herpes simplex 1 causes encephalitis and encephalitis does not have meningeal signs. If you're answering as B, herpes simplex 1 encephalitis will not have meningeal signs. You don't have a Brudzinski sign. We are talking about viral meningitis. What is the number one cause of viral meningitis? It is enterovirus. I think this was an easy question. Child with viral meningitis, all you had to do was lymphocyte देख लो. By history 2 days का ना यार, ये history 6 weeks 8 weeks का होता है. Tuberculosis सोच लेते. Whenever in an Indian exam you gonna sit, you will get a question on meningitis. If it's gonna be long history with lot of lymphocytes, grossly elevated proteins, it's tubercular. If it's a short history, it's a viral etiology. The number one cause for viral meningitis would be enterovirus in the patient. The answer to this question based on a short history is viral meningitis. Why answer is not B? Because it causes herpes encephalitis. Encephalitis causes loss of memory. It causes bloody CSF. You know, one of the important features of herpes simplex encephalitis is bloody CSF. Bloody CSF is not, there is no RBCs given in the question, no? If you listen to herpes simplex encephalitis, I've said there's a memory loss, weird behavior, agitation, and most importantly, blood in the CSF. Absolutely, Avinash, bloody CSF is not given in this question. The answer to this question is option number A, and this kind of question is usually asked in the exam. I mean, meningitis, hyponatremia, those are bread and butter kind of questions for the examiner. The answer is alpha. Yes, Dr. Padmini, you've given the correct answer. Moving to the next one, hot favorite of our national board, AIDS positive truck driver, and then they have asked about fever, cough and breathlessness, there's bronchial breathing, there's a lobar consolidation in the chap, CD4 count is also low. So anyway, I mean, AIDS positive patient will have problems. There's going to be opportunistic infections occurring in these patients, and he says, which of the following would you be thinking as the leading organism responsible for it? He has mixed it up with microbiology in this particular case. Option A says Pneumocystis jirovecii, which is the first one. This is Pneumocystis jirovecii. You can see those black cysts, and what is the stain present here? This is gomorymethamine, and gomorymethamine will be having a greenish appearance. The answer to this question is not A, guys. The answer is not A. Why are you falling in the trap again? Answer is not A. I'm still getting the feed as option number A. Why answer is not A is because in Pneumocystis jirovecii, do you have bronchial breathing? Absolutely not. There is in Pneumocystis jirovecii, there are hardly any findings. Maximum you will get crepitations. Maximum you will be getting crepitations. You are not going to get a bronchial breathing. Bronchial breathing is a feature that you always encounter with lobar pneumonia. And the number one cause of lobar pneumonia happens to be pneumococcus. In this particular question, which has been asked in the exam earlier, don't fall for the trap set by the examiner of CD4 counter 200 and answer is Pneumocystis jirovecii. Answer is not option number A. Pneumocystis carinii would not have a lobar pneumonia presentation and will not have bronchial breathing. If you X-ray is usually normal in those patients. No, here question is saying that X-ray is showing right lower lobe consolidation. If you listen to the video in the infection segment, I mentioned Pneumocystis jirovecii will be maximum having in extensive cases bilateral hilar infiltrates. It's infiltrates, hilar, which is described, not a lobar consolidation. So if you look at the information given in this question, there are two things against Pneumocystis jirovecii. X-ray is mostly normal in Pneumocystis jirovecii. Bronchial breathing is not heard in Pneumocystis jirovecii. If you're saying option number D, तो यार ये जो blue और red वाला बैक्टीरिया दिखाई दे रहा है, ये blue और red वाला जो होता है, ये तो वो Ziehl-Neelsen stain है ना? और Ziehl-Neelsen stain तो क्या पकड़ता है? माइकोबैक्टीरियम ट्यूबरकुलोसिस. तो क्या मैंने आपको ट्यूबरकुलोसिस का हिस्ट्री दिया है क्या? मतलब यहाँ पे उसको जो शॉर्ट फीवर, कफ, ब्रेथलेसनेस विद ब्रोंकियल ब्रीदिंग, लोब कंसोलिडेशन. सो tuberculosis is definitely an opportunistic infection in an AIDS positive patient, but then tuberculosis does not produce these findings of consolidation and bronchial breathing with a short history. I mean, I'll describe a longer history, and TB is anyway not a first infection. I mean, first you should think in terms of Streptococcus pneumoniae. If you look at option number C, यहाँ पे bacteria सब cluster in grapes में. When the bacteria is in cluster of grapes, that would be Staph aureus. Pneumococcus is a diplococcus. तो आप देखो ना यहाँ पे दो डॉट्स दिखाई दे रही है. कहीं कहीं पे दो की जगह पर तीन जगह डॉट भी हो रही है. जैसे देखो यहाँ पे ये दो डॉट्स दिखाई दे रही है, डिप्लोकोकस है. The correct answer for this particular question is a diplococci. The diplococci that we can pick up from the gram stain is option number beta. Hi, Dr. Med. Hi. The correct answer for this particular question is option number B. First of all, please understand the number one cause of pneumonia in a AIDS positive patient is not Pneumocystis jirovecii, it is pneumococcal pneumonia. It is community acquired pneumonia because these patients are gonna be coming from the community itself. In this particular question per se, the bacteria was not mentioned and it was rather the gram stain image that was given here. The correct answer for this question is option B. Sir, for people saying C, sir, that would be grapes, no? That cluster of grapes is what you see with Staph aureus. So do have a quick look at it, and I think that all of you would be able to solve it. I mean, I would say, not a very demanding question, because this happens to be a repeat one and has been discussed earlier also, as couple of guys have commented. Okay. Let's look at who answers the next question first. A patient with adipsia. Cytomegalovirus will cause retinitis, no doc? Dr. Ibiza is a party place, right? So cytomegalovirus will contribute either to colitis or it will contribute to retinitis. It will contribute to blindness. Yep. Chalo, great. Moving to the next one, electrolyte imbalance that will occur with adipsia. Yes, CD4 count, doctor will mention, it matters, but then alone CD4 count is never diagnostic, no? Because if a guy is coming from community, there is a high probability he got the infection of pneumococcus, plus you need to look at the findings. I mean, if this bronchial breathing was not given, he said few scattered crepitations. X-ray is either normal or shows perihilar infiltrates. Sir, if you're having doubt in this question, my request is just scroll down in the app, go to the infection component, listen to Pneumocystis jirovecii, hardly 10 minutes. That will clear off your issues why the answer is not jirovecii. Moving to this one, adipsia, the guy is not drinking water. If the chap will not drink water, sodium values in the body will jump up. Pretty straightforward. Hypernatremia, liberal water intake is to be recommended. If the values go more than 158, he can definitely have development of seizures. In those circumstances, I would be using in this patient 5% dextrose or N/2 and 5% dextrose for management purposes. Answer to the current question, electrolyte imbalance with adipsia, would be hypernatremia. I mean, if he's not drinking water, if SIADH is there would be hyponatremia in the patient. So see, you guys are answering brilliantly. Disability of old people, restricted water intake is what is commonly a problem. Very good. Yes, Deepak, you're right. Ibiza, you're right. Mubin, you're right in your answers. Moving to the next question. The question talks about heart failure. And he is asking you regarding what would be the cutoff for ejection fraction if you say heart failure with a mid-range ejection fraction. So we have a heart failure with the preserved ejection fraction. We have a heart failure with the reduced ejection fraction. And we have a heart failure that occurs with a mid-range ejection fraction as well. We'll just use the same color. You very well know the fact that for reduced ejection fraction, the ejection fraction should be less than 40%. For preserved ejection fraction, the cutoff is kept to be more than 50%. So when I say mid-range, it has to be between this, no? That would be something in the range of about 40 to 49%. Either equal to 40 or 40 to 49%. The correct answer for this question would be option number C. It's just a question based on terminology. I mean, if you have read about preserved ejection fraction and reduced ejection fraction, which are artificial cutoffs, preserved does not mean it is 65%, it means it's in the range of about 50, and for these patients most of the time we'll be using ARNI. That would be sacubitril and valsartan for management purposes. The correct answer for this question is option number C. Moving to the next one. The question says you are doing a transradial catheterization. Yes, Avinash, you're right. 40 to 49 is the correct answer. We move to the next one. The question says you are doing a transradial catheterization for balloon angioplasty. So there's definitely a possibility of complications developing in this guy. And he says, what could be the complications? Yes, Avinash, you bang on spot. The correct answer is option number C. You've done a transradial catheterization for balloon angioplasty. We might even be deploying a stent in the coronary artery of this patient, and we have punctured the radial artery. So whenever you puncture a radial artery, there are bound to be complications, no? Though we use a technique which is called a Seldinger technique. But you're putting a metallic needle in this patient, and the question says what could be the big complication developing? Yes, guys. Yes. So every time you are gonna be putting a needle, a metallic hypodermic needle in the artery, then the artery will undergo a spasm. Because of development of this spasm, what you will notice is there would be a change in the color of the extremities. The hand will become cold, the fingertips will become relatively pale and will turn towards blue, and then might even develop a possible gangrene. If your answering is option number C, bleeding, for this case, please be clear, you are there to prevent the bleeding. The answer to this question is not option number C. Please remember, bleeding is not the number one complication that should be monitored, because you are supposed to, I mean, it's okay, bleeding can occur, but you will apply a pressure bandage, no? You will apply a tight pressure bandage and tell the person, if you're taking a radial access or a femoral access, you tell the patient, don't move, hilna bhi nahi, pani peene ke liye nahi uthna, call us, press the bell, we'll help you drink water with straw. We don't want him to move this hand. We will not, yes, canagliflozin, yes, we are using it, not exactly in heart failure, doc, but we are using canagliflozin to improve the status of diabetics in heart failure. The correct answer for this particular patient is a big problem, that is, needle can cause vasospasm, it can even cause a thrombus formation. It is option number B that will be answered. I mean, whenever we take a vascular access, bleeding can occur, agreed. But then bleeding is something that we are supposed to prevent with pressure bandage. मतलब आप क्यों हो, आपका काम ही यही है bleeding नहीं होने देना. बड़ा सा हेमाटोमा बन जाएगा ना, उसको डिस्ट्रेस होगा, पेन होगा, तो हम हेमाटोमा नहीं बनने देते. लेकिन जो एक कॉम्प्लिकेशन ऐसा है जो कि हो सकता है, इट इज अ बिग प्रॉब्लम, इज बिकॉज यू इंट्रोड्यूसिंग अ मेटालिक नीडल. If you are introducing a metallic needle in the artery, you know, this I've described even in Allen's test, no, when I've talked about ABG section, I've talked about this, that when you introduce a metallic needle, vasospasm will occur. So we need to look at the perspective of the fact that there could be a narrowing present. And angina तो खैर से नहीं होगा ना, angina का तो इलाज कर रहे हैं ना इसको. We are treating the angina of the chap. Now, if you're putting a stent in the artery, you're trying to neutralize the spasm component. So answer to this question is option number B. Okay, moving to the next question. This chap had food poisoning and he was having vomiting. So the nurse gave him Perinom, metoclopramide, and now he's having dystonia. Thrombus, not embolus, Ritvik. It's not embolus. It will be thrombus, no? Because metal needle, it will cause a thrombus formation here. No? This will occlude and therefore they can be gangrene also. No? Every time you do a vascular procedure, that risk always has to be explained. Dr. Shilpa, sinus arrhythmia is already present on the channel. In the previous FMG salt paper, I've discussed sinus arrhythmia. So you can go through that. And anyway, I'll be taking more sessions before your exam. So I'll incorporate one more ECG of sinus arrhythmia. Okay. It will be totally normal, sir. RR interval change हो जाएगा. Don't remove the needle na immediately. Okay ji. Child is client with food poisoning. Patients are nowadays clients, and he is having a dystonia extrapyramidal syndrome with metoclopramide. No, very common. If you worked in the emergency and you given Perinom, you will notice that extrapyramidal syndrome will develop in the patient. He says which of the drug will relieve. We are talking about treatment here. Yes. Okay, Dr. Ritvika, sorry, my apologies, Dr. Ritvika. Yes, guys, what are you going to do in this case? This is a ACE inhibitor, so I'm not going to use it. Haloperidol will not be given in this case for treatment of dystonia. It will worsen. I mean, if you give haloperidol, it will cause dopamine depletion, no? It will worsen the dystonia of this particular patient. Metoclopramide is also decreasing dopamine. Haloperidol will also decrease dopamine, so it will worsen the extrapyramidal syndrome. Benzodiazepines are given when a client or a patient of yours is having convulsions or seizures. He's not having convulsion. Look at his body posture. No, गर्दन ऐसे move हो गया, arms extend हो गया, एक arm flex हो गया. You know, there's a weird posturing occurring. So what will you use in this patient? You will be using an antihistaminic drug. Benadryl जो होता है, जो Benadryl cough syrup होता है, उसी की बात कर रहा हूँ. That is gonna be diphenhydramine. So the answer for this question is, thanks doc. I'll be happy if you just address me as a teacher only. Diphenhydramine is the drug that we will be using in this particular case, or if you don't have diphenhydramine, you can even use Avil in these patients. But this is a very common problem that we encounter in our emergency, especially in pediatric cases. Summer coming up, you know, you would be having this nausea, vomiting coming up with diarrhea, and if you use Perinom, even with a single shot of Perinom, this complication can occur. So you would be using antihistaminic drug diphenhydramine for these patients. Okay, the answer to this question is perfect. Dr. Saad, you're right. Dr. Mantu, you're right. Dr. Muhammad, you're perfectly right in your answer. So moving towards the end of our discussion, a few more scattered questions and then we are done for today. Mitral cells would be found in which area? So always there will be some questions that will cause a bit of distress, as I've said, and there would be some which you will be able to solve. This is kind of a question that if you, yes, Avinash, you're right. It is an antihistaminic with an anticholinergic property. Exactly. So this is a nasty one. Doc, if extrapyramidal syndrome is occurring, yeah, I can use Abel or I can use diphenhydramine in a patient. Mitral cells are found in, then yes, this is a kind of a question that should ideally be, I mean, if you've read about it, great, otherwise you can let it go because there's no concept behind it. It's pretty straightforward. Mitral cells would not be found in mitral valve or Ashcombe nodules. They're rather found in the olfactory tract. So more of a kind of a question that if you've gone through in anatomy, great, otherwise you can let it go. The answer to this question is option number C. Yep. Moving to the next one. You are putting a central line in your patient. CVB monitoring is what I'm talking about. You are putting a central line. I have given an image for representative purposes. In the exam, they will not be giving you any image per se. So when you are putting a central line in a patient, you always have a reference 0 point. Normal CVP of a patient will be in the range of about 2 to 6 millimeters of mercury. You are already aware of the fact that CVP and JVP both are not going to be the same. The question says that Phlebostatic Access. Yes, it's more specific. Olfactory bulb. Yep. You see the central line will have to go in the right atria. The central line has to go in the right atria. So Phlebostatic Access means that you have to place the catheter. I mean the catheter tip should be very close to the right atria. What you do is you count ribs from here. First rib, second rib, third rib, fourth rib parasternally. When you reach the fourth rib, what you will do is from the fourth rib, you count the ribs here, right? Then from the fourth rib, you draw a line like, this is mid-axillary line. This is mid-axillary line. From the fourth rib, you draw a line which bisects like this. This is the mid-axillary line and there is a vertical line drawn from, I'm drawing two lines here. One is from the fourth rib and second is mid-axillary line. Where they meet is your right atria, that is the fourth intercostal space. The answer to this question that I put up right now before you is not the fifth intercostal space, it is fourth intercostal space. It's okay. I mean, for pneumothorax we use fifth intercostal space. For putting in a chest tube in the triangle of safety, we put in the fifth intercostal space. But when they talk about this central line, when they talk about this Phlebostatic Access, meaning of the word Phlebostatic Access is intersection of A and B. B is understandable, mid-axillary line, and A would be, you count from the intercostal spaces, fourth intercostal space parasternally, you would draw a line which would intersect line number B, and this intersection is the one which is going to be the location per se, that is going to be the location of the right atria. और वो जो location of the right atria है, that is where the central line should be present. मैं आपको call back करा दूँगा. It is at the intersection where I'll be putting in the center line. So the answer to this particular question would be given as option number beta. Yep. Let's move on to the next one. The question says which of the following would be correct? The question says which of the following would be correct with respect to acute glomerulonephritis? Yes, guys. Yep. This is option number B. Yes, Dr. Alam, you're perfectly right in your answer. We're moving to the next one. So, yep. Let's go through the remaining ones quickly. Yeah, doctor, the sessions are going to be conducted 4 p.m. to 6 p.m. That's the standard date timing where various faculties would be conducting it. Yes, Sagar, you are right. That logic can definitely be used. That's okay. I mean, T4 to T8, so that's fine. Your logic is perfectly right, Dr. Sagar. Coming to question number, coming to this question, which of the following is not correct about acute glomerulonephritis? Yes. Acute glomerulonephritis will be an intrinsic cause of acute kidney injury. You very well understand, no, pre-renal causes, renal causes, and post-renal causes. So the problem here would be that this is a renal cause. So this is okay. So you have to practice it, do it on a daily basis, and you will come out with flying colors part. Don't worry. Just go through the videos at a fast pace. Okay. RBC casts are pathognomonic but not required for diagnosis. Little tricky statement, let me analyze it for you. RBC cast will help you in diagnosis of glomerulonephritis, understandable, but because there are so many causes of glomerulonephritis, no? It can be post-immune glomerulonephritis, it could be Berger disease in a patient, it could be post-streptococcal glomerulonephritis, so etiology cannot be found out. I mean, meaning of the word option number C is that because there are various varieties of glomerulonephritis, post-immune, Berger, PSGN, so we anyway need a biopsy to identify the etiology behind it. Otherwise, we will just say glomerulonephritis because we are not aware of the etiology. RBC cast will help you in diagnosis, but will not tell you the etiology behind the development of the disease. So that is why option number C is correct. We have to select between option number A and option number D. Lot of guys have said that FeNA less than 1. Now I just want to tell you that this is a exception in a sense that this is an intrinsic cause, but the FeNA value in this condition is less than 1. Why? Because of the fact that in this condition tubules are normal. You see, tubules are functioning normally. This is not a case of acute tubular necrosis. In acute tubular necrosis, FeNA is more than 1. See, this is not AGN. It is this is not ATN. ATN, fractional excretion of sodium, is more than 1 because tubules are damaged, so sodium will not be absorbed. The most common cause why you get glomerulonephritis is not PSGN. The correct answer for this question, and I think most guys picked it up right away, was the leading cause of this is Berger disease. It is not post-streptococcal glomerulonephritis. When I'm answering D, the answer for a lot of people would be, sir, why is it not gonna be option number A? Then I want to bring to your notice that whenever it comes to acute tubular necrosis in a patient, acute tubular necrosis, the FeNA values can vary, right? But when it comes to FeNA values, I mean FeNA is more than 1 in acute tubular necrosis, understandable. That is because the tubules are busted, so salt will not be absorbed, so urinary sodium will also be high. But when it comes to glomerulonephritis, the values would be lesser. If you go through the video of acute kidney injury, I've explained this in detail, FeNA, urinary sodium, and how to differentiate between the varieties. You need to understand acute glomerulonephritis is an example of intrinsic renal disease, but will not have a FeNA value more than 1. The learning is acute glomerulonephritis is an example of intrinsic renal disease, but the FeNA value is not more than 1. It is less than 1. The logic is simple. Tubules are not affected. Tubules sodium absorb कर लेगा, urinary sodium कम हो जाएगा, तो FeNA की value भी कम हो जाएगी. The answer to this question, as I mentioned here before you, is option number D. So guys, my objective today was mainly to focus on the fact that we can keep on making mistakes in our final exams. I mean, whenever we go to our exams, there will always be some silly mistakes that we are bound to make, but then those mistakes should be used as a stepping stone so that we can improve our performance on a regular basis. And my objective today was mainly to sensitize you to the fact that don't get bogged down by this. I mean, this is a part and parcel of learning. This is a part and parcel of learning. So if you got these correct, there is no need to go and party. Right? And if you got them correct, there is no need to be depressed. This is part and parcel of this medical field. Okay. So we just need to keep on doing questions on regular basis, and gradually wisdom will come. And whatever you're studying will not, your hard work will not go waste. आपको लग रहा है ना कि मैं पढ़ रहा हूँ, दिमाग में नहीं जा रहा है, वो लगता है यार, वो सबके साथ होता है. आप न्यूरॉन्स को इतना टॉर्चर करो, खींच रहे, मार रहे उसको, पढ़, तो उसकी वजह से इश्यूज हो जाते हैं. सो Dr. Ritvika, my suggestion would be to try and exceed whatever you did yesterday. Suppose, let me say yesterday was my bad day. I studied 4.5 hours, only 4 hours or 3 hours, something like that, right? So today, instead of trying to worry about what happened yesterday, I'll say, okay buddy, not a problem, let's try to fix at least 7 hours, 8 hours, whatever are possible today. Let me focus on today, next hour, break it up into micro topics, and I think you guys would be able to yeah, Vinash, I will do. I'll do multiple sessions. So this is just the starting. I mean, I just needed that trigger. The PL people, PrepLadder people just pushed me to do one session, and once that trigger is on, then I won't stop. So I am with you. I'm with you to in this fight for survival, fight for being a better person than we are, fight for getting a good rank. And yes, so thank you so much for hearing me. God bless you. And I'll be logging out of the system now, and keep working, keep hammering, as I always say. In fact, that thing has become a little old now, that keep hammering part. But thanks, guys. God bless you and take care.